Well, good afternoon, everyone, and thank you to everyone for coming today, particularly those who have come from far-off places like Adelaide and Melbourne, I think is most of you. Good afternoon. My name is Professor John Jurians. I'm the director of the Whitlam Institute within Western Sydney University. And I warmly welcome each of you to the Whitlam Institute Policy Forum, celebrating the Whitlam Community Health Program, Lessons for the Future. Well, thank you very much for allowing me to introduce and commence this policy forum. It's now my privilege to introduce Kobe Newell, who I invite to give the acknowledgement of country.
Thank you very much, John. Weeaboo, Gujiigu. That is hello, we are coming together to meet in my Indigenous language, Gatang. It's good to be with you all today, and yeah, as John said, I am a proud Whitlam man from the mid-north coast of New South Wales. That's from the Port Stephens to roundabout Foster area. And my grandmother had the privilege to grow up on country, and I'd like to acknowledge her today. But I've grown up on Darug and Gundungurra country in the Blue Mountains, and today I'm here to acknowledge country. But I like to take some time and say, well, what is country? Is it the land? Well, part of it is. Is it the beautiful river that we see outside? Yeah, part of it is. But country is much more than the physical space that we see with our eyes. And it goes broader and deeper than the natural environment. And country is the language that has been spoken into this landscape for thousands of years. And today we are on Barramudagal country. And I'd like to recognise the Barramudagal people and their connection to the land. And the Barramudagal people have occupied this year, and archaeological estimations show up to 40,000 years, but according to Indigenous story, since creation, since the beginning of time. And so they are part of the broader Darug nation. And Barramuda means the place where the eel goes to lie down. So this is quite a sacred spot in terms of the ongoing breeding and I guess the ongoing of significant totemic animals. And so I'd also like to recognise elders, both past and present, and thank them for their wisdom, their knowledge and their guidance. And Western Sydney University has strong connections with our Indigenous brothers and sisters. And Western Sydney is connected to broader lands than just this. They are connected to the Wiradjuri, the Eora, the Tharawal, and also the Darug lands, which we are here. And we'd like to also appreciate the elders associated with Western Sydney University. So as we move forward today, may we walk gently on this country and take time to reflect the stories and the journeys that have happened on this land for thousands and thousands of years. Marangbu, thank you.
Thank you, Kobe. This forum presents findings from an ARC project compiling the history of the Whitlam Community Health Program. The project is a partnership between investigators and researchers from the Stretton Health Equity at the University of Adelaide, Flinders University, Trobe University, the University of Sydney, and partner organisations, the National Aboriginal Community Controlled Health Organisation and the Sydney Local Health District. The 1973 Whitlam Community Health Program planted the seeds of a transformative advancement of the Australian healthcare system. By 1976, the program funded over 700 projects, including community health centres in metropolitan and rural areas, women's refuges and health centres, family planning services, Aboriginal community health services, workers' health centres, specialist training for general practitioners, and foundation chairs for community medicine in universities. Today we'll hear from Professor Fran Baum AO, the Chief Investigator of the project, a keynote address from the Honourable Mark Butler MP, with time for a Q&A, research presentations, and a panel discussion after the break on policy lessons. Now, Professor Baum is a Program Director of Stretton Health Equity in the Stretton Institute at the University of Adelaide. She's a public health social scientist with a special interest in creating healthy, equitable, and sustainable societies. From 2009 to 2021, she was a Matthew Flinders Distinguished Professor and Director of the Southgate Institute for Health, Society, and Equity at Flinders University. She has held multiple grants from the National Health and Medical Research Council and the ARC, which consider health inequalities, inequities, and public policy, community health and social determinants of health, and health in all policies. I invite Professor Baum to the lectern.
Thanks very much, John, and welcome everybody. And it's lovely to see so many people in the audience who have in the past been part of community health, who are currently part of community health. That's a nice acknowledgement of the many nations of First Nations people in Australia. And I'm here to give you a quick overview of the project. One of the things we wanted to do with this history was draw lessons for contemporary policy. And you will find on your chairs some of those lessons that we think we have learnt. And you can look at the policy recommendations we will be talking about. I'm just going to give an overview of the research because we wanted the Minister to hear something of what we found. And he's very generously staying with us for about 2 hours, which I think is a long time. So we really appreciate that. And then later on, you will hear from other members of the team about detailed aspects of the history. And I'd also like to say that Pat Turner from NACCHO was one of our investigators, and unfortunately Pat isn't very well, so she's had to send her apologies. So how did we do the history? Well, we had archival material from community health services. We did a very critical review of policy, both within 3 states, New South Wales, Victoria and South Australia, from 72 to 2021, assessing how supportive it was or wasn't of community health. We interviewed 93 people who had worked in community health or had been involved in a policy role, and that included GPs, nurses, social workers, psychologists, and directors of community health centres, who had subsequently, in some cases, become CEs of hospital departments or local health networks. What we were really celebrating is the Community Health Program for Australia. You can see the original cover of the report, which said that unfortunately the emphasis in the delivery of healthcare has been on the provision of curative rather than preventive health and rehabilitation services. This imbalance is in need of urgent adjustment. Accordingly, the committee has outlined the scope for an initiative in community health, which is complementary to the proposal outlined in the health insurance report, which of course introduced Medibank. And another part of the report said the community health services under particular consideration are those that are provided in the community where people love, work or play. So that shows you, I think, some of the original flavour of that original programme. And the sad thing is, I think particularly the top quote would still be said about health policy today. Now, the central points from that programme, other than that, well, first of all, it was about, there was concern about growing chronic conditions, and apparently a quarter of us had chronic conditions then. I think we're now up to about half the population. The community health, community care was proposed as reducing the need for hospital care. It was said that welfare and community health services needed to be better coordinated because there was a confusion about services. Multidisciplinary teams were seen as desirable, and education and training for working in that community setting was seen as desirable. The key factors, these are sort of the headlines of what we found, and I'll go through each point quickly, but it was the need for supportive policy, the importance of social movement, how governance is very important to a health service, having a range of service types that are available to all the population. Again, the multidisciplinary team. There's some clashes we noted between professional interests and community interests, a strong focus on social determinants and advocating on those, and taking action with other sectors. And we also noted very uneven state development and the fact that centrally community health is concerned with health inequities. Now, we found supportive policies are absolutely vital, and that's just some examples. So in Victoria, there was a ministerial review which ended up supporting community health. There was a women's health framework, a strong women's health policy. And in South Australia, I'm very proud that we had a social health policy way before people were really talking about the social determinants of health. And that was really groundbreaking at the time. But I have to say, if we look at unsupportive health policies, we also now have to look to South Australia out of the 3 states we looked at. There's been a real move away from comprehensive primary health care in our state, a demise of community health centres and Aboriginal health teams within the health department, and also the demise of the primary prevention plan. It's the only time I've known a government formally withdraw a policy, which was the primary prevention plan. And also the health promotion unit, which had worked with community health centres, was abolished. And you'll see in a bit, and you'll hear later, about the strength of the Victorian movement and the different style of community health services in New South Wales. Social movements we found were crucial. In a way, it's like the policy was sort of the upward angle and the community was the bottom up, to sort of, really create a good community health service, and the movement. And it was very much a movement in the 70s. So there was the Aboriginal lands right movement, the feminist movement, the workers' movement through trade unions, establishing workers' health centres, the LGBTQI movement, which argued for needs for specialist services, a strong international community health movement, which I think inspired some of the work in Australia. And there was a kind of spirit of collectivism, not a sort of rampant individualism that's come along, I think, with neoliberalism. And also we found a number of health professionals who'd returned from working in low-income settings like New Guinea, where they'd really developed strong community care. We found that governance is really important and that community control and ownership is not easy, but it is very important. And this quote, perhaps I'll just read the one at the bottom. I think the original model was based on a set of values around community ownership and control, and I think that was a great aspiration. And on the top is from another study that we've done in the past about the Central Australian Aboriginal Congress, and just stressing how important it was that the patients to the service also felt that they controlled the service. And all the evidence we have on having control, that in itself is good for your health. And the really other thing that community health does really well is access to health services. And that's usually judged in terms of availability, affordability, and acceptability. And community health services do well on all 3 of those. An example of the sort of outreach was that the community health centres would do things like publish their annual reports in newspapers that were very accessible to community members. There's an example in the quote there that their meetings used to have 10 interpreters, and very often people would ask the questions for people who didn't like to speak in public. So a very strong emphasis on ensuring that people were able to have that say in their own health service. Very different from going to a private GP. And of course, a range of services. Yes, they offer one-to-one services, and in most cases medical services, but not all. There were quite a few in South Australia that had a range of other health professionals but didn't have medical services. So there was strong, there is and there still is in Victoria, obviously, and in the Aboriginal community controlled sector, one-to-one services. Many of the centres offer groups. They use the strategy of community development, which is working very, very closely with communities. And they also undertake social action and advocacy about the health of their local communities, which means addressing social and commercial determinants of health. We've actually, when we had centres in South Australia, we studied the value of group work, and this is a paper that Toby Freeman led, where we looked at the values of groups, what difference they make. And we found that they give people skills and knowledge, obviously, but they they also increase access, and one example I quote is where we used to have Nunga lunches in the south of Adelaide, and a podiatrist would come along there and would persuade people with diabetes to actually go and see a podiatrist, whereas if they hadn't come to the lunch, they probably wouldn't have done that. And then support, people give each other support, whether it's diabetes, mental health issues, parenting issues. Coming together in itself is good for your health. And then about empowerment and solidarity. So this person said, you're not just saying to people, you are the problem, you're saying that the structures are the problem and we have to work together to get them different. So really avoiding a victim-blaming approach of individuals, but saying this is a community issue. And this is a nurse we interviewed from country Victoria, where she just commented how powerful community development was. And she talked there particularly for drug users and HIV/AIDS, and how the community development let local communities know that there was support for them and that they could have a voice in what they were doing. A women's health centre in Adelaide used to have a community garden, and someone said a woman might come for a pap smear and leave with a lettuce. So there's that sense of it being a supportive place for people. But sadly, in South Australia, there's been a real narrowing of focus, and one of the workers said that community development became close to illegal. You couldn't get funding if anything had community development in its name, which is, if you read the original Whitlam program, community development was very much at the centre of it. And as we said, multidisciplinary teams were vital. Effective teamwork to offer that range of services. You need a mix of professionals, complementary strategies, emphasising teamwork in training and ongoing staff development. We certainly picked up some tension between the medical profession, particularly the professional associations and community health. The AMA was very oppositional to community health in the early days, in the 70s and 80s, although we found that often GPs on the ground were. I know in South Australia, one of our good community health centres at Clovelly Park was next door to a GP practice and did work closely with them. And in the original programme, there was a great programme called the Foundation for Multidisciplinary Education in Community Health that was based at the University of Adelaide. That is the only organisation I know that really did multidisciplinary training in people's initial degree. So it'd bring together doctors, nurses, social workers and so on. And community health is very good at centering community and having a social view of health. And this quote just says, will you emphasise on local solutions to local problems, but with an overall vision? Again, an example from South Australia. This was back in the early 90s. This is one thing we picked up in the history, that the Lettuce Community, Women's Community Health Centre had a fantastic project working with trade unions, working with the Working Women's Centre about outworkers, mainly migrant women who were paid very little to do sewing in their own home. And they looked at the way they were being exploited and brought them together to try and challenge and do something about that. And of course it was affecting their health, trying to keep up with the work they were meant to be doing. As we said, there's been very uneven development. I think our shining examples are now in Victoria of independent community health services, and of course our network of Aboriginal community-controlled health services. Those services are those that probably come nearest to the vision that the Whitlam program had at the beginning. Though I should say in New South Wales, there were community health work that was good, but it was happening within the State Health Department, and Denise Fry will tell you more about that later. There was also a lot of research and evaluation, even though that report in South Australia thought there wasn't. I've been director of the South Australian Community Health Research Unit for many, many days till we were defunded as part of the closing up of community health. But in Victoria, there was fantastic work by a woman called Yolande Wadsworth, who worked with a lot of community-based services and really broke ground in showing what kind of evaluation you needed to do to show the value of these services. And of course, equity is absolutely at the heart of community health. And that's just examples from Community Health First in Victoria and the Alliance of Rural and Regional Community Health. I was a keynote speaker at their conference a few weeks back, and it was wonderful to be in a room full of community health people who had that kind of spirit of collectivism and wanting to do things together. And I'd like to acknowledge in New South Wales, Liz Harris is with us today, and Liz did amazing work on health equity equity in New South Wales from within the health department and really putting that on the agenda. So equity is very much at the heart of community health services. In kind of intellectual terms, we've really seen a shift in some states, but even a little bit in Victoria, I think, from what some of our respondents said, from a very comprehensive primary health care to a selective primary health care. And a comprehensive primary health care is about being community-driven, being collaborative, working across sectors, having a long-term plan for health and well-being, not just picking up people sort of downstream in the river. It's about prevention, promotion, treatment and rehabilitation. And it's developmental and really grounded in social determinants, whereas a more selective approach is much more narrow. And there can seem a lot of logic to adopting a selective approach. Oh, we know what the diseases are, but you're really losing a lot by not going upstream and stopping the flow of people into ill health. And of course, what community health really does very, very well is work with people for whom the health system, whether it's GP, hospital, or whatever, are very difficult for them to access. And this is a quote from a nutritionist who worked at Noarlunga Health Services for many years in South Australia. And she said, I think the value of community health is that at its best it addresses inequity. That means that you get to work with the most disadvantaged, most marginalised people in society. I think community health at its best was that part of the social system that brought dignity and honour to those people who were most marginalised. And I'm sure that's what Gough Whitlam had in mind and his cabinet when they decided to have that 1973 Community Health Program. So thank you.
It's a privilege now to call upon the Honourable Mark Butler, the Minister for Health and Aged Care. Mark Butler has been a Labour Member of Parliament since 2007. He previously served as Minister for Ageing and as Australia's first Minister for Mental Health in the Gillard government. He has also held the ministries of housing, homelessness, social inclusion, climate change, water, and the environment. He has long been a champion for society's most vulnerable and was a member of the South Australian Social Inclusion Board during its major review of the South Australian mental health system. Mark was with the United Voice Union for over 15 years, 11 as State Secretary. Following Mark's address, the Minister has graciously made himself available to take a few questions. We will have 2 roving microphones. If you have a question, please raise your hand, and either Viv or Mita at the back there, dressed in black, will come to you where you are seated. Minister Butler, you have the floor.
Thank you, John. Thank you, Fran, for that terrific overview and for the work that you do. We all know each other in Adelaide, if we're not related, and so often both. And so Fran and I have known each other for some time. She's a terrific, not just South Australian public intellectual, but a real treasure for the country. So thank you for the work that you're doing now, but the work you've done in public health for many, many years, and to Kobe for your acknowledgement of country. It's quite... It's a little bit terrifying having the great man look over your shoulder. I was the member for Port Adelaide until outrageously the Electoral Commission abolished that electorate and put me into the electorate of Hindmarsh, which many of you students of Whitlam history will know was the seat that Mick Young went into after he had served Gough as the National Secretary of the party. And Gough took Mick to his first trip to China along with him, forging relations with the Communist Party over there, and very strong party-to-party relations that really were the foundation of the trip as Prime Minister the next year. And Mick has this, or had this terrific big framed photo of Gough that was left to me, I guess, as the member for Port Adelaide, and I have it behind me for all of my Zoom meetings that we do a lot of nowadays. So when stakeholders and various other rent seekers and all the rest sort of zoom in, they see the sort of Gough staring at them intimidatingly, as I can feel him doing over my left shoulder. You know, as we mourn the loss of a giant of the Labor movement who never got to be Prime Minister but made an enormous contribution to his country in Bill Hayden right now, and that's why John is not with us, of course. It's so fitting that we come together and think about the legacy of that amazing group of people, not just in the government, in the cabinet, but around him, people who were urging the election of a government like Gough's to modernise the country. Gough had done such extraordinary work, recognising, along with people like Mick, Clyde Cameron, another great South Australian, that to modernise Australia, he first had to modernise the party, because for all of our shortcomings and failings, and we have a number in the Labor Party, progressive change would only ever happen through a Labor government. And there would only ever be a Labor government if the party modernised. And so Gough just had an enormous body of work to do, you know, modernise the Labor Party, get into government, and in a very short period of time, change the country. Bill played a huge role in that. And towards the end of the government, as the sort of economic consequences of the 1974 oil shock really were bearing down and changing what people had taken as the sort of comfortable assumptions of the post-war global economy, he also, this is Bill, he also, I think, set the foundations for the Hawke and Keating governments of the 80s to be able to continue that progressive reform agenda that was started by Gough, but also to have quite a different approach to the management of the economy, to frankly the approach that Gough and his team had in the first couple of years of their government. So we mourn Bill and we thank him for his extraordinary contribution to the country most importantly, but as a Labor Party person also to our party. I want to echo the acknowledgement of country and pay my respects to the elders past, present and emerging of the Barramuttagal people of the Darug Nation. We've just gone through a very challenging period of time in our long journey to reconciling with Australia's First Nations people. And one of the really striking things about what was a really difficult process as much as the result was the role that young Indigenous leaders emerging to positions of leadership played through this campaign. And I think the generation of Indigenous leaders that are very familiar to us, I think have really acknowledged the role that the next generation of Indigenous leaders played in this very difficult referendum campaign that was, in too many instances, toxic, deeply distressing to First Nations people, but something that saw something of the resilience that Fran talked about in her acknowledgement of country. So I want to, at a very challenging time for the country and its reconciliation journey, pay my respects to elders past, present of the local community, but really of communities right across the country. It's a real pity not to have John here, but I want to acknowledge the work he does for the Institute. He is really the great custodian of Labor history in our party. He does it in his unique, slightly grumpy way. Lots of finger wagging to people like Nick and to me and to others, but he is an absolute jewel of our party, and he is a constant reminder, sort of over our shoulder a bit like Gough is, of the need for us always to be true to our roots and our history and the mission of the Labor Party, which even though the application of it will change from time to time, in many ways in its core elements is quite timeless. So I'm really sad that John can't be here, even though we completely understand why he's up in Ipswich. As you all know, the legacy of that amazing government in health policy is difficult to overstate. But while much has been written and said about Medicare, and will be over the coming couple of months as we move to the 40th anniversary, and its precursor, Medibank, the contribution and the legacy of the Community Health Program, as Fran and her team of researchers have reinforced through this project, is significant, if less well known. The CHP, it must be said, would likely have faded into obscurity were it not for the work that Fran and her team at the Stretton Health Equity Institute at my alma mater, the University of Adelaide, have spent many years documenting and bringing back to us. What I'd like to do today, though, is to provide some of my own reflections on the lessons of Whitlam CHP and outline a bit about how our government, the Albanese government, is trying to integrate those lessons and particularly those principles in our reform program to strengthen Medicare. As Fran outlined, the CHP was a recommendation of the National Hospitals and Health Services Commission in 1973. That commission produced two major reports at the time. One report was handed to Bill, who was the Social Services Minister, and recommended the creation of a scheme of universal health insurance that came to be known as Medibank. And the other report, which is not as well known, was handed to Health Minister Doug Everingham and recommended the creation of the CHP, the Community Health Program. And as many of you know, before they both entered politics, Bill was a Queensland cop and Doug Everingham was a Queensland GP. And it's hard to find two men with a greater legacy in Australia's health policy than Bill and Doug, because together they planted the seeds of a policy that would grow into the oak tree of universal health insurance, a visionary and truly nation-shaping policy that faced a savage assault when they tried to introduce it, and did for really 25 or 30 years thereafter, where universal health insurance in many ways was the defining fault line in Australian politics between the left and the right. For those who haven't read it, I read on the plane this morning a piece by Mike Steckety in InsideStory.org, I think it is, on the history of Medicare, and it's a terrific read and reminds you what a great writer Mike was for many years as a full-time journalist. But it also sets out just the personal and vicious attacks that Bill back in the 70s had to endure, some really vicious personal attacks and completely untrue. And Neil did as well in the 1980s, which many of you will remember as well. It really was quite strident opposition from the medical fraternity, as it certainly was back then, the medical community, particularly the AMA, just as the BMA had done in the 40s when Curtin and Chifley were building their program of universal health that ultimately at least ended up in the PBS. Medibank was a universal insurance scheme to provide low or no cost access to a private industry of medical doctors, providing mostly episodic treatment on a fee-for-service basis. And that really, in many ways, was a choice that government was constrained to make by the settlement that was entered into in the 1940s and the lead into the referendum that precluded on a constitutional basis nationalised healthcare or conscripted healthcare. So it was necessarily a private industry of medical doctors. The Community's Health Program on the Community Health Program's remit, though, was very, very different. Doug Everingham called it community health care rather than sick care, as Fran pointed out, and it aimed to proactively improve the health of the local community and not just those individuals who proactively sought and could afford care from a traditional doctor's service. And this meant a greater focus on health protection and prevention. It meant providing treatment programs and health promotion in areas like drug and alcohol, mental health, reproductive health, and many others. Underpinning the CHP was a comprehensive model of health that looked beyond the narrow medical reasons for episodes of illness towards a greater understanding of the social determinants of health. In contrast to the primary care industry, services at community health centres were free and universally available without referral, so for walk-ins, very similar to the way in which we're trying to build our urgent care clinic network, which I'll talk about a bit further on. They were provided by multidisciplinary teams of nurses and allied health workers, sometimes operating alongside and in partnership with local doctors, which then was quite unique. The CHP was there to fill a gap that Medibank simply couldn't, particularly for people with little access but a lot of need for good quality care. Because underpinning every part of the CHP was the foundational Labor principle of equity. That principle saw the funding, as John said, I think of more than 700 different projects around the country, from community health centres to women's refuges, family planning services, and importantly, given what it's grown into Aboriginal community health services as well. Instead of a uniform model of care imposed from above from Canberra, the CHP funded states, local councils and community groups for a wide variety of projects in a truly bottom-up and iterative approach to policy formulation and program delivery. The CHP genuinely let 700 flowers bloom. And the idea was to see what worked and then try to replicate as well as continue to innovate. But as is so often the case with visionary and nation-shaping Labor health reforms in Australia over many decades, the Community Health Program was opposed by a self-interested cabal of doctors' groups and the Liberal National Coalition. Only a couple of years after, the Fraser government dismantled Medibank, but it also defunded the Community Health Program, ripping Medibank from the soil and essentially leaving the CHP to wither on the vine. And wither it did. Slowly in some states and quicker in others. After another long winter of cuts and neglect to healthcare over those 7 years of Fraser, the Hawke Labor government was then elected in '83 and immediately restored the funding to community health. But while the funds flowed to the states and territories at that time, it was, it must be said, without the overarching ethos and drive of the CHP in the Whitlam era, as Bob Hawke and Neil Blewett, his terrific health minister, instead focused their attention on the restoration of universal health insurance through Medicare and frankly other emergencies like the emerging HIV epidemic. Medicare took root in the Hawke era, but the CHP, it must be said, did not. 50 years on now from Whitlam's visionary reforms, Medicare is now an oak tree of health policy in Australia. It's impossible to uproot entirely, which is not to say the coalition hasn't tried many times over the intervening decades. The father of the modern Liberal Party, which I mentioned from time to time in the Parliament question time, John Howard, called bulk billing an absolute rort. When he was Health Minister, Peter Dutton lamented that there were, and I quote, too many free Medicare services. Well, he tried his best to get rid of that. And after his infamous GP tax failed to pass the Senate, people will remember that he initiated a 6-year-long freeze of the Medicare rebate, which in many ways really is the reason why general practice in particular finds itself in the condition that it does today. But thankfully, in spite of those attempts just to hack away at Medicare, Medicare has survived those successive Liberal health ministers hacking at its branches with nasty cuts and with callous neglect. Doug Everingham's report, as Fran said, talked of rising rates, even back then, of chronic conditions and mental health disorders, of lifestyle diseases that simply can't be cured with a single episode of care from a doctor or a one-off course of medicine. It talks of confusing and increasing inefficient fragmentation of health systems, of gaps between primary care and hospital care, and a lack of clarity after hospital discharge. It talks of the need for multidisciplinary team-based care and better coordination between doctors, nurses and allied health practitioners. In fact, so much of the report that landed on Doug's desk reads just like the report that landed on mine earlier this year from the Strengthening Medicare Task Force. That report and the 1973 Hospitals and Health Services Commission report share a hell of a lot in common, particularly in the problems they identify and the opportunities that they see reform. And frankly, they share a lot in common with Christine Bennett's Hospitals Reform Commission report that was delivered to us in 2009, as well as the Preventative Health Task Force, the Primary Care Strategy, and so much besides. None of this is new. None of this is particularly rocket science. But where the 1973 report called for a principled program of health delivery to sit alongside what was then Medibank, the 2023 report calls for Medicare to be strengthened by integrating many of those same community health principles into Medicare itself. And at this year's budget, that is exactly what we began to do. We are strengthening Medicare by listening to communities and putting patients at the centre of healthcare. That was such an important element of the CHP 50 years ago. Patients have too often been locked out of decision making, and so the budget allocated $13 million to strengthen the capacity of the fantastic Consumers Health Forum and to seed the creation of a new body for culturally and linguistically diverse Australians in healthcare. 2 new national mental health consumer peak bodies will also finally be established to ensure that consumers and carers finally have a say in mental health policy. I allocated money in the budget in 2012 for that to happen, and 10 years later came back to government and found that it hadn't. Not sure what happened with the money. It certainly didn't go into funding consumer advocacy and mental health. We're strengthening Medicare with a new rebate for GP consultations longer than 60 minutes to give GPs the time that they need to provide better care for patients with really complex needs. That new rebate took effect only on Wednesday, along with the single largest investment in bulk billing in the 40-year history of Medicare. The tripling of the bulk billing incentive will begin to restore equity and universal access by making it easier for 5 million kids and their families, as well as 7 million pensioners and concession card holders, to see a doctor free of charge. After 9 years of cuts and neglect that saw bulk billing decline sharply, particularly over the last few years after the impact also of COVID and then the global cost of living shock, GPs are calling this investment a game changer, saying it will help them maintain or even shift back to bulk billing where they've felt forced to move away from it. We're also strengthening Medicare by fostering the kind of multidisciplinary care that the CHP envisioned and in some areas was actually able to deliver. This starts by giving GPs the support they need to grow their nursing and allied health teams by increasing the workforce incentive payment to general practice by up to 30% as a one-off increase, and for the first time indexing it every single year. Smaller practices that might not have the ability to employ their own practice nurses or allied health practitioners will soon be able to call on the services of those practitioners and nurses through a $77 million program for PHNs to commission and then deliver practical support to some of those smaller general practices in the community. And I really want to see this area innovate. I want to see this commissioning fund start to underpin some social prescribing in primary care through the use of social workers, to have much more use of mental health nurses in general practice than we see in many parts of the country, particularly outside Victoria, and those sorts of areas of innovation as well. We're strengthening Medicare by supporting every health professional to operate at the top of their skills, their training and their experience. Professor Mark Cormack's Unleashing the Potential of Our Health Workforce Review, which he commenced over the last couple of months, will find the opportunities for everyone in our very highly educated health workforce to provide every ounce of care that they're able to. I want to see every health professional work to the top of their scope, but we particularly need to break the glass ceiling that has held back our highly educated, very large nursing workforce for far too long. The first batch of consultation took input from across the health sector over the last several weeks and closed last month, with more consultation opportunities next year before the final report is delivered by Professor Cormack sometime around October. We're also strengthening Medicare by addressing that gap between hospital and primary care, with 58 Medicare urgent care clinics rolling out across the country, all to be opened by the end of this year. As of this week, 35 of them are already delivering services, and the remaining 23 will be opened in coming weeks. This is a model of care, as many of you know, that's pretty common around the rest of the world, to which we usually compare ourselves, but just hasn't been able to take hold here in Australia. These clinics provide urgent care for patients with non-life-threatening emergencies. They don't need a referral or appointment. They're able to walk in, and all they need is a Medicare card. It's open 7 days a week for extended hours, often till about 10 p.m. at night, and has already seen about 52,000 episodes of care in a relatively short period of a few weeks. And interestingly, a third of those services have been delivered to kids under the age of 15. I've often been talking in my media commentary about this, about kids falling off their skateboard. Apparently that happens quite a lot. So in Ipswich, where John is right now, the urgent care clinic there talked about a story of a 12-year-old who'd come off, actually not come off a skateboard, fractured their wrist at basketball, were triaged within a few minutes, literally 5 or 6 minutes, x-rayed, had the splint applied, and was really walking out within 90 or 120 minutes. We know what would have happened otherwise, particularly if it was on the weekend or after hours. They would have spent maybe 6 or 8 hours at an emergency department, a pretty challenging environment, and taken hours to be cared for after that waiting time. So a third to kids, a third of services are being delivered on weekends when really no one can get to see a general practitioner. And of the weekday services, 1 in 5 of the services are being delivered after 6 p.m. as well. And in keeping with the ethos of the CHP, these urgent care clinics are very much trying to be framed around local needs. We want to see a wide range of types of application of this model so we can evaluate it and hopefully over time be able to scale it up. In the ACT, for example, the Territory Government already had, as you know, a well-established network of nurse-led clinics, which my colleague Katie Gallagher, when she was the ACT Health Minister, initiated, again with very significant opposition, it must be said, from one particular stakeholder group. We're now going to support and extend that by melding this proven model of care in the ACT with our urgent care funding. We're also strengthening Medicare by going beyond fee-for-service with the introduction of our new My Medicare program. My Medicare is the foundation upon which a stronger, more personalised Medicare will be built. Patients will get more tailored quality care from their regular general practice or other primary care service, their doctor and their primary care team. Practices will get better information about their registered patients, particularly as we're able to lift the digital health capability of the health system, which frankly lags any other significant sector of our society or our economy right now. My Medicare will help Medicare go beyond those limitations of fee-for-service with a range of blended funding packages to help practices tailor their care to patients from priority groups, like in the first instance, frequent hospital users that might be attending emergency departments 10 times or more in a given year, and aged care residents as well. And you know as well as I do, we have not been able to crack the nut of delivering good quality primary care services in aged care facilities with all of the consequences that we're familiar with. The first of those packages are going to become available in the middle of next year, but already nearly 200,000 patients have registered with My Medicare in the last few weeks, and 4,500 general practices have also registered. The benefits of this system-wide reform will grow over time as more patients and providers join. I'm really committed, though, to making sure that this one sticks. I mean, you've all been involved in primary care a long time. I cannot count the number of different pilots and attempts we have made to develop new blended funding models and to find ways of strengthening the relationship between patients, particularly with high needs, and their primary care practice of choice. We're also strengthening Medicare by growing and supporting, frankly, the jewel in the crown of community health in this country, and that's the community-controlled Aboriginal health sector. As Fran often remarked and has often remarked, ACHOs remain one of the few really modern examples that fully embody those principles of Whitlam's CHP, and I couldn't agree with Fran more. The work that ACHOs do isn't just a model for First Nations communities. It really is a model for the whole sector. And Dawn Casey's membership and contributions as the Deputy CEO of NACCHO in our Strengthening Medicare Task Force went well beyond what she needed, what her organisation needed for First Nations Australians. She taught the whole of that task force about what works through a good deep model of community control. And since coming to government, we've invested nearly $1 billion in new initiatives to improve First Nations health outcomes, and almost every one of those dollars is being channelled through that community-controlled sector overseen by Nacho. Through all of this work to deliver a stronger Medicare, our North Star has always been patient benefit, putting patients before profit, consumers before providers when the choice is a stark one. Our government will always make tough choices and face down any opposition in the service of patient benefit, whether that be in providing health and hip pocket benefits from 60-day prescriptions for chronic disease medicines, or in squaring off yet again against big tobacco as we reignite the fight against nicotine addiction in that old form of cigarettes and that newer insidious form of e-cigarettes or vapes. After all, it will be remembered it was Labor Health Minister Doug Everingham who first took a stand against big tobacco profits on behalf of patients by restricting for the first time the advertising of tobacco products. The fight he started 50 years ago continues today. But even as we strengthen Medicare with the principles of Whitlam's CHP, Medicare's underlying architecture remains a universal health insurance scheme for a private industry of medical and some other health practitioners. We need to be clear-sighted about the strengths and the limitations of that purely private market model. In 1974, at the opening of the CHP-funded Maroondah Social Health Centre in Melbourne, Gough said this. He said, "It's equally wrong that people in some areas should have available a more than sufficient number of doctors to provide medical treatment, while people in other areas suffer a shortage of doctors." Whitlam's attempt to right that wrong, of course, was the CHP. And we have to recognise that today it's not just doctors that are not distributed equally across the country. I've been dealing over the last several months with the impacts of an evaluation of the Better Access Scheme, a scheme that provides Medicare benefits to clinical psychologists, principally, for the delivery of psychology therapy. And just as the evaluation of Better Access that I received when I was Mental Health Minister over a decade ago did, this evaluation shows that the distribution of clinical psychologists across the country is even more inequitable than the distribution of doctors and other health practitioners. The difference between the richest quintile of Australians and their access to good quality evidence-based psychology therapy and the poorest quintile is jaw-dropping. And we know that the poorest quintile have profoundly higher levels of mental distress than the richest quintile for a whole range of reasons that Fran and other researchers in this room are very familiar with as they categorise the social determinants of health. So it's not just a doctor male distribution that we are trying to deal with. It is broadly the health workforce, and it's frankly not just rural and regional Australia anymore that suffers from these disparities. There are real deserts of access to good quality healthcare in our cities now, particularly the bigger cities as you move into the peri-urban areas. And in many ways this is getting harder to fix. There are a range of distortions happening in the labour market that are restricting the tools that I feel I have as the National Health Minister to try to improve that equity. 10 years ago, when confronted with those gaps in psychology therapy, for example, we were able to pour very substantial amounts of money into a program called ATAPS, an access to psychology therapy, that effectively just delivered bulk billed services in communities of low access. Now, the distortion of the psychology workforce by better access means state services are finding it very hard to recruit clinical psychologists, and I think we would find it hard to find the clinical psychologists who would be able to be available in the northern suburbs of Adelaide or parts of Sydney, parts of Melbourne, let alone rural and regional Australia, where you simply cannot find a private clinical psychologist to go and get a better access service. We're finding exactly the same with general practitioners as the locum market grows substantially and the fees for locum GP services skyrocket to, in some cases, several $1,000s a day. simply means that many GPs are moving away from full-time work into part-time locum work and creating an even more significant challenge for us in making sure that we have enough GPs to deliver the services that we need. We are focused on trying to deal with these workforce challenges through a mix of innovation, particularly focused on building the work of other health professionals like nurse practitioners. Really trying to find ways in which we can have innovative models of care in rural and regional Australia, particularly in thin markets that are able to combine some of those health services with services funded through veterans, through aged care and through the NDIS. Often the same organisations are involved in all of those programs. How do we pull that a little bit better? And a review of the long-standing programs of what we now call the distribution priority access areas, the old districts of workforce shortage, that help determine where overseas trained doctors are or are not able to practice. This is all very challenging work at a time where the entire globe is experiencing a workforce shortage in health. We are not immune from that. These are very challenging drivers, if you like, of the principles of equity that we're talking about today. In conclusion, can I say, as we near the end of what I think is a really big year of delivery, indeed a big week of delivery on our commitment to strengthening Medicare, our government hasn't wasted a day in building on the legacy of those great modern Labor governments that came before us. Indeed, not just the modern governments, but also Chifley's pharmaceutical benefits scheme, making sure that that is fit for purpose and built around the needs of modern patients rather than the patients of decades gone past. But also Whitlam's Medibank, his community health program. And next February, obviously, will mark the 40-year anniversary of Medicare. 40 years of universal health insurance uninterrupted, a visionary reform that has endured despite, as I said, decades of cuts, decades of neglect from the coalition, and at really critical embryonic stages of the reform, really strong opposition from within the health sector itself, particularly from doctors. We know that there is more to do. There's a lot more to do as we build a stronger Medicare. Strengthening Medicare for the next 40 years is going to mean reviving those principles that are set out in Whitlam's Community Health Program. It really is. And to integrate them much more deeply into what we now have as the Medicare system. To ensure that Medicare is not just a safety net, as so many of those in the coalition would like to limit it being, but by weaving the ethos of the CHP into Medicare, will strengthen it beyond its health insurance roots, from universal health insurance to universal health care, or what Doug Everingham, as I said earlier, would have called community health care rather than sick care. Thank you very much. Thank you, Fran, for your research, and all the best for the rest of your service.
A few questions?
Yeah, sure.
We have about 5 or 10 minutes to take some questions, and Kathy or Viv, we'll come to you. You have a question of the Minister. Thank you so much for your extra time.
Thanks, John. No questions? Okay, thanks.
I really appreciated your comments about Aboriginal community control of health services. But I want to make a point that one of the most important things they have done is to address the structural determinants of Aboriginal disadvantage in terms of continued pressures of assimilation and racism and so forth. In that context, I'm reflecting upon your emphasis on clinical psychologists as a mental health strategy, and wondering whether there is not more to be done in terms of looking at the social and structural determinants of poorer mental health. I'm thinking in particular of the accelerating degree of economic inequality in this country, and the experience of alienation and anger, which was manifest so strongly during COVID and also manifest during the recent referendum. And I wonder I suggest that individual clinical psychology is not the solution, but that learning from the Aboriginal community control, the health sector, it might be building strong institutional base for community advocacy to address those kind of things, which I didn't really hear from your from the program that you set out.
So, I'm working with a group of people in mental health about how we respond to better access, the evaluation. And you're absolutely right to say that access to clinical psychology is not the silver bullet for what is, it would seem from ABS data we got only a few weeks ago, sort of an inexorably increasing level of mental distress in the community, particularly among young people. So we've been trying to think sort of carefully about that. I had a great discussion with Pat Dudgeon and Helen Milroy a couple of days ago, who really have been the leaders in Indigenous mental health for many years now, about the role of Indigenous healers and the work they do to build that resilience and a model of early intervention that is in no way clinical, if you like, about people who are experiencing mental distress in the sort of general sense of the term, not necessarily a diagnosable mental illness in the DSM sense of the term. And I think I'll deal with the sort of the health system aspects before I get to the what's happening in the community and in society. I mean, I think one of the things we're grappling with in this mental health group that I'm working with is that there, I think, is a degree of pathologisation of sadness, stress, the response to the inevitable knocks in life that you take, and often a sort of the easy path for people to be channeled to is a psychologist, for psychological therapy that might not be necessary. So are there low intensity levels of support if you can't get them from your own personal network of family and friends? Are there other low intensity levels of support that you see quite commonly now around the world, talking therapies in the NHS and a bunch of others, that aren't clinical services, aren't dependent upon a clinical diagnosis of mental illness, but try to sort of intervene early to get people back on the track as they deal with the consequences of separation, grief, loss of job, those sorts of things. That is one of the things we're trying to do. The other is to deal with the question of some of the drivers of these escalated levels of mental distress in the community, particularly among the young. You know, some of them are very familiar: poverty, isolation, a sense of disconnect or disenfranchisement from your society, and a lot of that was elevated, that disconnection through COVID. But frankly, what we also saw in many communities is that the lift in job seeker reduced levels of mental distress in very poor communities who, for the first time, felt a little bit more financially secure. So COVID was there was quite interesting things to take from that period of time. I think what we're all grappling with is what's happening to young people. And that is, like, you're seeing very, very high levels of distress, particularly among younger women. So the sort of late teens into early 20s, as high as almost 50% in the past 12 months. And what we're not seeing is while the sort of a spike in levels of mental distress in late adolescence and early 20s is not new. You know, as you move through these life transitions, you know, into adulthood, in middle age, into very old age, you see those big spikes in levels of mental distress and mental illness. What we're not seeing currently is the tapering off as people move into their mid-20s that we have historically seen. So I think there's a lot of thinking and research into what is driving that. Social media, I think, is a big part of it, the ubiquity of it. the difficulty young people have from disconnecting from it, its toxicity. So we are looking at a range of things in this group, many of which would be traditionally called social determinants, but some of them are quite new, and particularly that social media environment and some of the things that younger Australians are grappling with today that my generation and most of you wouldn't have been dealing with when you were their age. As for the sort of broader challenge you make, I guess, about not including that in my speech, you know, I want to say whether it's in strengthening Medicare or in our work that we're doing with NACCHO, and I was there at their conference last week, sort of working through how we would reignite that after the result of the referendum. You know, we as a Labor Party will always try to have health equity and a good lens on social determinants right at the centre of our public health policy. And I hope that you would see that through an initiative like the bulk billing incentive change that we made this week, the biggest increase to bulk billing in the 40-year history of Medicare. I mean, it will make a profound difference to the ability of low-income Australians to get free healthcare in this country. A guarantee that was frankly slipping away really fast before we made this intervention this week.
Thank you, Minister. I'm very reassured about your understanding. It's really very comprehensive. At one stage I was the CEO of a standalone community health centre. I'm now on a board in Melbourne, but this was a rural one. And the local high school had a huge issue with self-harm and cutting. They were in a low socio-democratic place. We made the decision to have one of our drug and alcohol workers go and be based at that school one day, and it was increased to 2. And ultimately that school wanted to employ him, so they did, and we got another worker. But that made a huge difference, and I think young kids aren't going to walk into even, you know, welcoming community health centres. They need to be able to access things in their environment and where they are. So I think, you know, I know there are, like some schools work very hard at this, but there have to be funding incentives to support that. And I think the same can be said around family violence. You know, I had family violence workers that I just felt they couldn't turn off the tap. It was just relentless. So, look, I won't keep talking, but I just appreciate your comments.
Thank you. Fran's a great believer in health in all policies, and I think in South Australia, Jay Weatherall, who now heads up the Thrive Before 5 program at Minderoo, was before he was Premier, a great believer in trying to integrate health services and other services into early childhood. And so some of the early learning centres he built in South Australia are not just staffed by educators, but have a whole range of different health services available, particularly in vulnerable communities, and they're delivering terrific outcomes. So that idea of trying to sort of find opportunities, opportunistic care if you like, and intervention through schools and early learning and a whole range of others is something we should do more of. I think prisons is one of the areas that I'm currently working very closely with NACCHO and other groups about. This was a recommendation from the Royal Commission more than 30 years ago that we deliver better health care in prisons, particularly for Aboriginal prisoners. Nothing really has happened there. Now, states will say, give me a Section 19 exemption so we can, you know, basically send you the bill for pretty substandard health care. I'm not going to do that. What I am interested in doing, though, is looking at some of the models that we see at Don Dale up in the NT, we see it in Alice, we see it in the ACT prison, where Aboriginal community controlled health organisations are funded to go in and deliver health care. It's community controlled, it's connecting with prisoners they were familiar with before incarceration and with whom they'll continue to have a relationship after incarceration. So how can you build sort of health into some of those opportunities is something we're thinking about, particularly in places of vulnerability, so communities of vulnerability, and in locations like prisons. Your comments about youth mental health are absolutely spot on. Like, you know, when I was young, the only opportunity you had to get some help was to go to mum and dad's GP. So unsurprisingly, no one did. I mean, I think the rates of access for young men and male teenagers who needed care accessing it was 7%. Like 93% were not getting it. So the building of youth-specific mental health services like Headspace and a range of others besides, and digital services, has been a game changer. But they're reaching their limits. I mean, they were designed as sort of pretty basic primary healthcare services, and what they're struggling with now is what Pat McGorry calls that missing middle, which is a high level of complexity of many young people's needs that is beyond the capacity of most primary care services, but not yet at a level of severity that would trigger an intervention from state acute services. So we're working with him on that. You see through the Head to Health centres, which really came out of the Victorian Royal Commission into mental health, you see a bit of that starting to build for adults. We haven't yet got it, I don't think, for young people, so that 16 to 24-year-old cohort, which after all we know is where about as much as 2/3 or 3/4 of mental health disorders emerge. We've got to build a solution for them that they feel comfortable with. And as you say, if there are opportunities to in-reach and deliver some of those services in schools, increasingly we know sometimes not just high schools, it's in primary schools, in early learning, to build that strength, then we should be looking at doing that as well.
We have one final question.
Who do I go to?
Denise Fry is my name, from New South Wales. Thank you very much, Minister. One of the findings of our study, both in our policy analysis and the oral history interviews, was the almost lack of knowledge, one could almost say amnesia, about the community health sector and the program from the Commonwealth Department of Health. And what we found is that there seemed to be an assumption once the Commonwealth stopped funding community health services that somehow they didn't exist anymore. And even looking at some of the main sources of information that the Commonwealth produces now, such as the Australian Institute of Health and Welfare's reports, the productivities reports on government services in health, there's almost no mention of community health services at a state level, and also no data. So it's not surprising that most of the recommendations that you would receive and your Commonwealth Department would make about primary health care and community-based services are GP focused. So I guess what I'm asking for is how are some ways which the community health sector can be part of Commonwealth and federal policy proposals, and how could you make your department more informed?
Well, this is one way. You know, I've come here and spent a couple of hours learning. Simon Cottrell's here, so hop into him. Go your hardest. You know, I'm a firm believer if you don't measure it, it is, you know, at a particularly a national government level, it is hard to do anything about it. I'm really delighted Nicola Roxon agreed to become the new chair of AIHW. That's such a terrific organisation. There's more it can do. I had the great pleasure of working under Nicola as a junior health minister to her for a number of years, and her parliamentary secretary before that. So get into her as well. If you need it, I'll give her your mobile, her mobile. Look, I think there's a lot of truth to that. That you know, there are so many challenges in health. If we're not in the space already, it is hard to get a federal department to move into a space it's not familiar with, that's sort of lost capability about. But you know, I'm really worried about where primary care is in this country. Like I've said, I think general practice and Medicare is in its most parlous state for 40 years. I mean that. I'm terrified about the pipeline of GPs coming through and how we change that. There are ways in which we can address it by better using the rest of the workforce, but there are some really, really serious challenges at a time when demand's increasing because we're getting older, there's more complex chronic disease, there's much more demand for mental health services in the community, and general practices generally are the front line there. They do the vast bulk of that care. I'm really worried about where primary care is. And I think I feel good about what we've been able to do with broad support from the community and from the health sector over the last 12 or 18 months. But geez, we've got a lot more to do. This is a long piece of work for the federal government, working with states, working with the sector to deliver the type of primary care system that is true to the principles that we've held as the Labor Party for many decades, but also reflects the very different patient profile of Australia in the 2020s and 30s, with a much older, more complex patient. So I'm open to all ideas. At the moment, as I tried to say in my remarks, our focus has been on trying to integrate those principles that your report, your research really draws out from the CHP, and integrate them into our strengthening Medicare reforms. If there are other ideas, I'm all open to them, because this is a long, difficult piece of work that we have ahead of us. All the best for the rest of your afternoon. Thanks very much for the invitation to be with you.
While the presenters are coming forward, I will quickly introduce each of them. Dr. James Dunk will speak on the origins of community health movement. James is a research fellow and historian of science and medicine in the School of Social and Political Sciences at the University of Sydney. Denise Fry, Denise, say hello, will speak on the community health in New South Wales. Denise is a research evaluation officer in community health services for the Sydney Local Health District and is an adjunct fellow, senior fellow, Stretton Institute, University of Adelaide. Associate Professor David Legg will speak on community health in Victoria. David is a scholar emeritus in the School of Public Health and Human Biosciences at Trobe University. He started his career as a physician, but moved early on into health services research, health policy, and public health. Dr. Toby Freeman will speak on community health in South Australia. Toby is a senior research fellow and the director of research at Stretton Health Equity, part of the University of Adelaide's Stretton Institute. His core research interest is how to address growing health inequalities and inequities. His areas of research include primary health care, Aboriginal and Torres Strait Islander health, healthy public policy, and social determinants of health. Closest to me is Dr. Connie Mussolino, who will address women's health. Connie is a research fellow at the Stretton Health Equity and has a PhD in gender studies and social sciences from the University of Adelaide. Connie is project manager for the History of Community Health project. Last, we have Associate Professor Tamara McKean on the end. Tamara will speak on Aboriginal community-controlled health organisations. Tamara is a Walajian woman, public health medicine physician, and fellow of the Australasian Faculty of Public Health Medicine. Associate Professor McKean holds a conjoint appointment with the FHMRI and the George Institute for Global Health, and leads a body of research in health equity and Aboriginal and Torres Strait Islander well-being. Each speaker will now have 10 minutes to speak, following which we will have an opportunity for a few questions. Might I first invite James?
Thanks, John. I just wanted to also add that I acknowledge the Baramatical people of the Darug Nation and pay respects to elders past and present. I'm just going to talk quite briefly about some international precedents for the community health program and some aspects of the political and economic environment and the medical culture in Australia that shaped the development and course of the program. There'll be some glimpses of community health as you know it, I think, developing across some of these quite small vignettes, as you'll see, which were these kind of instances often elicited by quite pressing needs and distinctive needs to particular groups over time. In the 1920s, in what was then the bustling trade hub of Winnipeg, Jewish migrants fleeing political unrest in Europe often found themselves excluded from public life and from social services, including healthcare. They founded the Mount Carmel Clinic in 1926, accommodating their language, religious and cultural needs, as well as basic healthcare needs. But from early on, the clinic served not only the Jewish people, but the entire community. The clinic's first executive director, Anne Ross, herself a Ukrainian migrant who trained in nursing, later described a set of what were then quite unconventional principles. I believe she wrote in the idea of treating the individual or family as holistic entities. Every person responds physically and emotionally to their immediate environment and to their network of friends and family members. I felt it was highly advisable to investigate these factors of function of an individual's general health. My position was that unending poverty, coupled with a constant struggle to survive, affected the individual in toto. But certainly the most celebrated early community health centre was established in 1940 at Folila, a rural community in KwaZulu-Natal in South Africa. Designed as an experimental model, it was led by Dr. Sidney Kark, who had studied medicine at Witwatersrand in the 1930s, and who, while there, was also influenced by historians and public health scholars and liberal academics who helped him to understand the interwoven economic, social and health problems affecting Indigenous populations and others. Drawing on the contributions and expertise of health experts in the Zulu community, not always entirely acknowledged, Sidney and his wife Emily developed a system of community-oriented primary health care that will be taken up throughout South Africa and resounded throughout the world. In the United States, community health opened in specific communities, in specific communities from the early 20th century. But in the 1960s, neighbourhood health centres were established as part of a national war on poverty, and emerging also in the train of the civil rights movement. These were at the same time healthcare centres and targeted interventions, developing communities by promoting health. Columbia Point Health Centre, the first fully fledged community health centre in the States, was established by Count Gibson and H. Jack Geiger. And Geiger had become acquainted with the Karks and with South African community health whilst a medical student, meaning that US community health was in part an African export. There was also the domestic economic context. Strong migration and industrialisation had generated a post-war economic boom. Steady growth and increasing government revenue allowed for the consolidation of the welfare state that had been gestured towards from the 1940s on. This economic context influenced shifts in turn in Australian medical culture. Along with a new welfare apparatus, increased government spending had produced a new popular expectation that health issues could and would be addressed for individuals. But administrators and economists saw a healthcare crisis looming. Costs were rising here as elsewhere, an average 11% a year between 1960 and 1970. But health outcomes were apparently plateauing, as the disease burden shifted from infectious to chronic disease. It seemed that existing health systems might not any longer be fit for purpose in urbanised industrial cities, with their so-called diseases of civilization rampant. And social medicine's perspectives continued to point to the health effects of rising inequality. First world states like the UK and the US therefore began to pivot, developing coordinated national healthcare policies to organise, rationalise and economise care through the community, or the world of the well. And of course, the political landscape, which we've heard quite a lot about, was also important. Healthcare here was constitutionally a state responsibility, except for quarantine and other powers, but the federal government was receiving an increasing share of revenue, and with it came moral responsibility for the health of the community. In 1946, the Chifley Labor government legislated to reduce the cost of prescription medicines. When 3 doctors successfully challenged the law in the High Court, afraid of the spectre of nationalised healthcare, the government called a social services referendum to increase federal powers in social welfare and healthcare. The No campaign circulated caricatures of Chifley as a spider trying to snare the states in its great welfare web. But after 30 years of World War and depression, there was political support for more expansive federal government, including for building health infrastructure. There were a number of other aspects of the Australian cultural and political landscape that shaped the community health program or fed into it. After the Second World War, Australia took control of New Guinea and responsibility for the health of its population. But because medical staff and supplies were limited and budgets were constrained, administrators had to think more pragmatically and creatively about how to provide basic low-cost primary care across difficult geography and cultural barriers. In response, regular medical staff were augmented with auxiliary local medical personnel, and the reach of care was extended beyond hospitals by satellite medical stations. New Guinea, importantly, became a training ground for Australian medicos and an experimental laboratory for administrators, and which would resound really through generations of Australian healthcare and continues to. And there were other specific pathways of influence and inspiration. Dr. Sydney Sachs, who chaired the national committee that authored the Community Health Program, had grown up in South Africa and also studied medicine at Witwatersrand in the 1940s, before working in local community health centres that were modelled on Flinders and working closely and knowing well Sydney and Emily Clark. When Sachs migrated to Australia in 1960, he brought much of their program of community-based, multidisciplinary primary care with him, as a physician and medical superintendent, and then as Director of Geriatrics for New South Wales from 1964. In that role, he worked to support older people to live independently in their own homes, which is also to say in their communities. Sachs gained some traction with the New South Wales Department of Health, so much so that a document released by the Minister of Health in 1972 observed a growing realisation that health is dependent to a large extent not only on good medical care, but also on the quality of our total social and physical environment and the extent to which we avoid known harmful influences. It mentioned also health education, early intervention, and local access. It should be possible to assess and manage most problems in simple settings close to where people live and work, rather than the complex environment of the hospital, it finished. As well as an imperial power, Australia was and continues to be, as we've heard and know, a settler state, with Aboriginal people groups subject to the continuing theft of land and official racism, including in these same decades, the removal of children, structurally. Structural racism meant structurally poor health outcomes. Established in 1971, the Aboriginal Medical Service was, like the nearby Aboriginal Legal Service, committed to community control to ensure that the needs of Aboriginal people would be attended to within these overwhelming colonial structures. From the 1960s, community mental health had been gathering in the wake of the closure of psychiatric hospitals, concentrating on care in the community and nurturing patients' rights and healthcare consumer movements. Hans Pols, I know, is here this afternoon, who knows all about community mental health. Meanwhile, the industrialising economy brought new industrial workplace risks. In 1964, the Australian Meat Industry Employees Union established the Trade Union Clinic and Research Centre in Paisley Street, Footscray, providing free medical care and preventive education for working people. It became the Western Region Health Centre and more recently CoHealth. Similar clinics sprung up, practicing occupational and environmental health, as well as drawing attention to the social and economic determinants of health. The women's health movement, part of the women's liberation movement, called for the liberation of healthcare from patriarchal control. Women must have authority over their own bodies and their own health, the advocates insisted, and education and community building were crucial in that work. The history of women's health, as we're going to hear, is intertwined here with that of community health, with the first Women's Health Centre opening in Leichhardt with a grant from the Community Health Program. To conclude this rather whirlwind of origin stories, the Community Health Program aimed for equity, access, prevention, education for individuals and communities and to encourage them to take greater responsibility for their own health. Many community health principles and models were first developed elsewhere, but they were adapted to the contours of the Australian political and economic scene, to its social fabric, and to its medical culture. Health culture, really. As the following presentations will show, the program of community health did not, in fact, encounter a singular culture or politics, but a plurality. It took different shapes in different states, according to things like the organisational structure of the health system in each place, the assertiveness of medical power, and stronger or weaker charitable sectors or cultures of voluntarism. This reminds us that ideas, practices, and even radical paradigms do not simply march across the globe, stamping everything in one shape. They're selected, imported, adjusted, rearranged, and sometimes, of course, weakened or truncated, and also, of course, perhaps revived and restored. Thank you.
Hello everybody, it's great to see so many people here today, particularly colleagues and friends from many years. I'd like to start by acknowledging we too are meeting on the land of the Burramatagal people of the Darug Nation and pay my respects to present, past and emerging leaders and any First Nations people here today. I'm going to talk about community health centres and services in New South Wales and how the New South Wales political and administrative context has had a dominant influence on the development of those services. So, first of all, as first steps, as most people will be familiar, health services delivered by the New South Wales Government in people's homes and neighbourhoods began at the beginning of the 1900s with baby health centres and some home nursing. And as James has mentioned, the role of Dr. Sydney Sachs is very important. There is Sid there in the New South Wales Department's keenness in taking up the federal community health program gains in the early 70s. Of the 727 projects funded by the community health program, 350 were in New South Wales. So that tells you something about the keenness of the New South Wales Department and also the range and variety of community health services which were set up, particularly in rural areas and out of Sydney, where there was a dearth of health services at that time. Now, if we think about what was distinctive about community health in New South Wales, there are several factors that have had a long-term influence. First of all, most community health staff who were employed as temporary public servants, New South Wales public health servants. And again, the community health program coincided with the establishment and the regionalisation of the New South Wales Health Commission. And this had a whole range of both diverse and contradictory effects. This meant that regional officers, which were new in themselves, had the capacity to interpret the community health program in a range of ways. Some focused on the very generalist focus, others tended to organise their services in ways that were aligned or linked to hospitals. And the other main exception, what have I done here? Is that there was very little primary medical care in New South Wales community health, in contrast in particular to Victoria, some parts of South Australia and the Australian Capital Territory at the time. And there was a range of reasons for this, perhaps the New South Wales government's reluctance and also the very strong opposition from the AMA at the time. But this also had an effect, which probably meant that other services tended to predominate. When we look at what else was distinctive, it's clear that some other areas that were relatively new, such as migrant health, health promotion, drug and alcohol services, and community-based mental health care were important elements. Health issues which had been given insufficient attention. And that component of community-based mental health, which was always an early part, an early element of New South Wales community health, was in contrast to other states. So that's something which is easily forgotten, I think. The other point is that perhaps that I think has been underappreciated is that many of those recruited to work in community health had social science qualifications and had not been, hadn't worked in the health system before, and I include myself here, and I can think of some of my colleagues in the audience as well. And I think this meant that without that professionalisation, socialisation in hospitals, there was a more open view. And our oral history interviews captured this sense of exhilaration and excitement and enthusiasm that people had in implementing a new approach. If we look at the impact of the Fraser government from 1975 and what happened in New South Wales, it was quite dramatic. In 1978, the federal Fraser government cut its proportion of community health grants from 75% to 50%. And in response, in New South Wales, the Rand Labor government, which had been elected in 1976, it proposed to delete over 400 community health positions, but hospitals were not affected. So, in response, community health staff and community organisations and trade unions organised what was called the Save Community Health campaign, lobbying politicians, holding demonstrations and arguing that community health services should not be cut but expanded in response to changing health needs. Now, New South Wales's response after this, this lobbying and this community campaign was to drop the deletions, but the way it dealt with the budgetary pressures was not to fill any staff vacancies. And not surprisingly, this resulted in a lot of service disruption and, of course, a limitation in service effectiveness. But at the same time, here's another of these contradictory responses. In 1977, the New South Wales Health Commission's head office published a series of multicoloured books which were known as the Rainbow Books, will be familiar to some people here today, which outlined a pretty clear conceptual and practical framework for implementing community health, but regional officers were not obliged to use it. So again, the Save Community Health Program, same Community Health campaign, then evolved into the New South Wales Community Health Association, which became part of the National Australian Community Health Association. And just as a reminder, that turbulence at state level was also happening at the national level. I think some people perhaps aren't aware that, again, there was a national strike to defend Medibank in July 1976. And when I looked at the Sydney Morning Herald's report of the time, it said that 2.5 million people participated in that strike. So the social movement was there at the time. Again, despite that very turbulent context in New South Wales, there was a lot of innovation. And some of the examples I've listed here include a program in the Everleigh Railway Workshops in Sydney, a huge establishment which both built and repaired railway carriages, and that people who were involved in community health there ran a large multilingual, multi-session education program with the New South Wales Railways and trade unions. Again, in Redfern in 1977, there was a wide range of programs which included skills for unemployed people, in-language programs for a wide range of mothers and women's groups, playgroups for children, interagency meetings on unemployment, as well as other programs. I suspect some of those programs today, responses from chief executives would be to say, not our stuff, that's not health, that's somebody else's job. Again, some more innovation. Again, some people here, I think, might remember that there were migrant health education officers which worked with a very wide range of communities, Italian, Greek, Turkish, what was then called Yugoslav, difference today. Arabic, Vietnamese and others were employed right across Sydney and also in some metropolitan and rural areas. Women's health services, and that's Leichhardt Women's Health Centre there, the front door, also expanded and offered a wide range of services, including responding to work-related injuries, contraception and abortion services. And then also in 1982, the New South Wales Health Department at the time initiated a project to develop standards and accreditation program for community health services in recognition of its distinctive nature, and I'm proud to have had some role in that program. Okay, but there's always a but. From 1981, there was large-scale organisational restructuring and industrial disputes in New South Wales in health. And from 1980 to 1983, there was significant cuts to community health services and regional offices as part of efforts to redistribute hospital beds to the west at the time. The New South Wales Department's Division of Community Health, the Central Division, was abolished in 1982, which meant there was little capacity for overall policy or coordination. And from 1986, the incorporation of community health services in area health services, and then from 2011 into local health districts, has meant that community health services have become a minority financial and staffing component in larger organisations that are basically focused on hospitals. So in this situation, in this political and administrative context, there is a tendency for hospital-focused systems to fragment generalist services into specialist teams and align those teams with hospital-based categories or monodisciplinary care. And again, that requires more complex service navigation and coordination. In the mid-80s, a review of community health across Australia, conducted by the Australian Community Health Association, found that community health was an established part of the health system and a firm base from which to reorient services to public primary health care, but it was shaped by the larger system to the detriment of its reorienting potential. And I think that finding has been and continues to be particularly appropriate to community health services in New South Wales. When we look at later developments, we see that there's no statewide policy or required organisational structure for community health services. So area health services and now local health districts are pretty much able to take their own approach. So there's very uneven development, and also, critically, there is little statewide aggregation or analysis of data. So we don't know about service organisation extent or gaps. And again, we do know from a 2008 review of New South Wales services conducted by Cathy Eagar and Alan Owen and others, that the overall percentage of community health expenditure has declined in some years. That study was done in 2008. There's been no work done since that time, so we don't know if this has accelerated, remained, or what. So this decline was attributed to an increase in short-term hospital management and also that uneven development. When we look at the current situation, we see that in some parts of the community health system in New South Wales, there's been some statewide policies and some service expansion, but no overall community health policy for many years. There's one policy called the Health One Guidelines, which was made in 2012, quite some time ago, which originally focused on bringing together GPs with community health and other health professionals in multidisciplinary teams. There's been some initial evaluation, but little since in the last 8 or so years. And it's hard to know how many of these current 27 Health One centres have GPs, or when I read the documents, how different they are to ongoing community health. The latest one is called RPA Health One in Green Square, called after a hospital. It's opened in 2023, this year. There's no GPs in it, but also there are some hospital outpatient services and some community health. So to sum up, despite the lack of an overarching policy or strategic approach for community health in New South Wales, there's an extensive but patchy and uneven system continuing. But we know there are increased population and there are waiting lists for some services in some LHDs. There's a variation in service content and organisation, and the lack of statewide data makes it difficult for policymakers to be well informed. So the comment I made about the lack of knowledge at the federal level also applies to some degree to the New South Wales level. This means that community health remains relatively unapparent or not visible to policymakers, and hospital demand and costs continue to dominate policymaking, and therefore that focus on hospital management reduces community health's capacity for prevention and early intervention. There is, however, from the Minns government, a current special inquiry into healthcare funding. So there's an opening there. Thank you very much.
Okay, so the story of community health in Victoria is rich with lessons for future policy and practice. I'm talking about generalist community health services. The Connie and Tamara will be talking about women's health and Indigenous health services. This slide lists some important stories about community health in action over the period. We're talking about public dental services, building support for new dental programs, air pollution struggles, looking at the health of sex workers, looking at gender-affirming models of care, the needle and syringe exchange program of North Richmond and the supervised injecting services. A lot of community health centres were involved in the COVID response with bicultural workers, outreach testing and human rights advocacy when it was needed. Community health has also been working with hospitals, an example being the hospital admission risk programs. Community health has worked closely with different multicultural communities, with peer workers working in those communities, and some quite amazing annual general meetings with many people from different communities, all being engaged through their participation in translation and interpreting. In terms of the research, the way we've put together the community health in Victoria research, we think that there's a rich literature testifying to the efficacy of the community health model, but we've not been seeking to evaluate that. We also think that there's been serious discounting at a health policy level of what community health can do. But again, we haven't sought to evaluate that. What we've sought to do is to understand the political and institutional dynamics which have shaped health system development over this time, with a view to identifying the facilitators and barriers to the wider implementation of the community health model, with a view to developing new approaches to policy, management and practice. So on this slide, we've divided the evolution of community health in Victoria into basically 6 phases of community health. The first phase is the generation of 1973, where there was intense opposition by the Balti government to accepting any Commonwealth money, which led to a lot of community mobilisation with strong input from the Labor Party, Labor activists working in their communities. The Hospital and Charities Act provided a surprising vehicle to enable community health societies to become incorporated organisations and receive directly Commonwealth money. And this culture of struggle and of working together led to a collaborative set of values which has lasted to the day. We've talked about the phrase a chill, but I think it should be we should locate this in the context of the stagflation of the late 1970s and the economic disaster of the time, which was in a sense global as well as national as well as state. And with that came the sequential cutting of Commonwealth funding. In 1983, we had the second generation. The Hawke government restored funding of community health, but not to the agencies, it was to the states. And in Victoria, there was an explicit attempt to redistribute the new Commonwealth money in a more equitable way. So a whole series of new community health centres were established, more or less top-down, in contrast to the bottom-up approach of the first generation. During the 1980s, the state government was very keen to get control of hospital expenditure, the state Labor government, and as part of that introduced things called health service agreements and moved from input budgets to activity-based funding. And these more or less managerial strategies impacted also on community health, with the increasing movement towards contracts, health service agreements and specific funding with key performance indicators. The period of Kennett in the early 1990s is a period of austerity. Obviously, Kennett and austerity go together. But it's also a period of high interest rates globally again, as well as nationally. And we had in Victoria two major financial collapses, as well as the South Australian State Bank collapsing. And so community health was being a victim of not just bad policy, but a bad economic situation and the recession we had to have. But during this time, what had started out as early managerialism under David White in the early 80s became full-blown economic rationalism, which we now call neoliberalism. And with that, we moved to competitive tendering, to the full marketisation of health services, and the offer of universal access to free healthcare was now unfunded. Many community health centres were absorbed into hospital networks, and we saw an expansion of hospital community health programs, but there was also the sector of independent community health centres which were adapting to this new environment. And the new environment included getting big or getting out with amalgamations so that people could pursue service contracts. And so a major part of organisational development was reaching out to get service contracts to deliver services, often in competing with private service delivery or voluntary service delivery agencies. Increasingly activity-based funding with contract-based funding and an increasing reporting burden. And with the increasing intensity of managerial, the transaction costs of management, the need to move to larger services with board appointments made on the basis of expertise rather than election from communities. But the bottom line is surviving the marketplace, where community health services have continued to make savings on some of the service programs that they get in competitive grant funding and being able to deliver programs of a community in accordance with community health programs principles through contract shavings. So how should we think about the political and institutional dynamics of which has shaped community health in Victoria? One which has been mentioned several times is the hostility of the organised medical profession, but it's important to locate it as fee-for-service funding, which is the barrier to any kind of to collaboration and to community focus. It's also important to see cost shifting as part of this deal, because the state was quite happy to receive Medibank money, Medicare money, to boost service delivery in a nice example of the cost-shifting disaster which has been Australian healthcare. Community relations is another important dynamic. With the long history of voluntarism in healthcare in Victoria, community health centres have been valued by their local communities, but importantly also by their local MPs, because they provide a nice backdrop for announcements of one kind or another. Community ownership has been weakened perhaps by the increasingly selective mandate, by the appointed boards and by the bigger agencies. And this is a point for further discussion, I think. A third dynamic is hospital relations. And this is a bit paradoxical, because on one side, the immediacy of the hospital waiting lists is always takes precedence over the need for community health funding. But on the other side, community health services are seen as a resource for increasing the productivity of the acute care sector. Really important is to understand evolving strategies of public administration as drivers. with increasing information systems, activity-based funding and performance indicators moving into much more importance, with marketisation of service delivery, public, voluntary and private suppliers competing for contracts on short-term, unstable bases. Another dynamic has been conservative scepticism come hostility. There has been a suspicion of discourses which speak about community or marginalised populations or social determinants. It's all a bit pink and we need to avoid it. The wider economic environment I've spoken about, which needs to be recognised, the problem of inflation and stagflation in the 1970s and the problem of massive high interest rates in the 1990s were external factors which were major drivers of what happened. However, under the heading of culture and commitment, I think we need to recognise the culture which was built out of the struggle of the early community health centres, the culture which was built out of adapting to the new challenges, and the way in which that culture and the commitment has been reproduced, notwithstanding some of the many challenges I've talked about. So, thinking through what this all means for policy and practice in the future, we've got 5 suggestions. One is that we should give more policy attention to the health consequences of inequality, alienation and social determinants. And these need to be responded to at the community level. To talk about doing it on a one-to-one basis is unfortunate. Community health has a massive contribution to make to this idea of responding to community challenges, community health challenges at the community level as well as the individual level. Secondly, we would urge attention to creating and expanding the institutions which can support best practice in community health. That means agencies outside the community health centres, agencies like the CHAS program that we've heard about, that the Foundation for Multidisciplinary Community Education, which Fran talked about, the Community Health Association, and all the academic centres which are helping to develop community health. There is an urgent need for that kind of institutional support for the community health sector. We need to reconsider managerialism, marketisation and the privatisation of human services. This is a major challenge to community health, which has had quite a negative impact. And the commodification of healthcare. Healthcare being thought about as being something that you count, as the Minister said, if you can't count it, you can't manage it. But that means that you commodify it and you make it into something that can be bought and sold, and it's not as easy as that. We need to reappreciate the strengths of service delivery through established institutions which have operational continuity, which have structured accountability, flexible budget funding, but managerial discretion in terms of responding to local needs, as well as accountability for the way in which that discretion is used. This is, in a sense, in opposition to the neoliberal model where healthcare is just a commodity for sale. And finally, we need to pursue the issue of blended payments for general practice as a precondition for developing the community health approach. Thank you.
Thank you. So my name's Toby and I'm going to be talking about community health in the far-off land of Adelaide, South Australia, where I'm lucky enough to live and work on the lands of the Kaurna people. And I'd like to add my acknowledgement of the traditional owners whose lands we're meeting on today. This excerpt from the 1984 review shows how, like elsewhere in Australia, the community health program really led to an abundance of community health services being established and run in South Australia. And I think from my reading of the interviews and these archival materials, one of the reasons it was so successful in doing so was because the funding so well matched the desires and goals of the health professionals, community groups and individuals who wanted to set up community health services to serve their local communities. And so quite a wide range of models grew up in South Australia using that program. On the top left is Clovelly Park Community Health Centre, which is not too far from where I live. That was set up, amongst others, by Dean Southgate, who our old institute, the Southgate Institute for Health, Society and Equity, was named after. And that was really quite an innovative, holistic approach to health coming out of that centre there. The bottom left photos of the Parks Community Centre, another really strong model, which occurred to me when he was talking today, would have been in Mark Butler's electorate. Right on his doorstep, and that was an excellent service again, with some really strong community development and advocacy initiatives coming out of it. And on the right, as Fran said, these kind of innovations in practice were accompanied by real innovation in research and evaluation on how do you go about showing the strengths and evaluating the benefits of community health services. Alongside the mainstream community health services that opened up, there was also a really strong women's community health movement in South Australia from the 1970s onwards, with one of the first ones being the Hindmarsh Women's Community Health Centre that opened in '76. And as well, we've got a really strong Aboriginal community-controlled health organisation sector in South Australia. And Pikawea was one of the earlier art shows nationally. It was perhaps about third in Australia, and was established with the help of expertise from Redfern. In the early 1970s, where a group of Aboriginal women met in Port Augusta to discuss, the health concerns that they had. And importantly, they couldn't get government funding. So one of the things we've heard in the interviews is that Aboriginal organisations couldn't always get access to that community health program funding. And they in fact got their funding from the World Council of Churches to set up Pikawea in Port Augusta in South Australia, which continues on today. And I'd like to highlight how these services existed in a really supportive ecosystem of other initiatives. So you might have heard of the World Health Organisation's Healthy Cities initiative, where there was 3 sites in Australia, and one of them was Healthy Cities Noarlunga, which again continues today as Healthy Cities Onkaparinga. The Foundation for Multidisciplinary Education Community Health, Fran and David have mentioned on the top left there. The top right is the social health strategy that Fran mentioned earlier. Mark Butler mentioned health in all policies, which was great to hear. And then the bottom right is the health and social welfare councils that were really quite an experiment in community participation in South Australia. So there really was a broad range of really quite pioneering strategies around taking this social view of health, as well as the community health services. And just to take it nationally for a moment, to emphasise how central equity was to the whole community health movement. So when the community health program money funding was made available, there really was a lot of effort put into making sure the services were set up in areas of socioeconomic disadvantage, and really designing it and putting a lot of effort into making sure these services served those for whom general practice or other primary healthcare services really were not that accessible, and focusing on groups like migrant communities, on people experiencing homelessness, in working class suburbs where they might not be able to afford a doctor. And to do that, there was a lot of innovation in practice, and a lot of it from the interviews seemed to be just driven by gut about what would work to achieve equitable community health services. Things like community governance, community development initiatives and intersectoral action. And I really like this quote from a Victorian interview, Tim Walsh, who gives 2 examples of such actions, really being locally responsive. So managing to get someone from the immigration department to come in and sit at a desk in the community health service to help, I think in that case it was particularly a Vietnamese community working to get all their paperwork done around their settlement. And then a really successful job, employment program with young people. That 8 out of 12 of them got into jobs after doing the program at the Community Health Service. So really innovative, locally responsive practices to reach those in the most need. So in the Community Health Program came in the early 70s. Some of the early initiatives I've just described are listed there on the timeline. So you see that innovation through the 70s and the 80s, and then that's when the wheels start to fall off after that. The Health and Social Welfare Councils were defunded in 1995. Community Health Service Boards were dissolved in 2004, and they established regional boards instead. And by that time, community health services had been renamed as primary healthcare services. That jumped ahead. And then in 2007, we had the GP Plus healthcare strategy, the name of which still baffles me today. But it really shifted community health towards a biomedical focus on chronic conditions and how to intervene with individuals with chronic disease so that they use hospitals less, because it costs less if they didn't use the hospital so much. In 2009, those regional boards I mentioned were dissolved. And then in 2012, as part of the GP Plus overall strategy, community health services got moved from their previous spaces, which typically were really designed to be welcoming, to be community-oriented, were designed in collaboration with community, and got moved into more clinical buildings. So this example is the No Longer Health Village in the south of Adelaide, which again was designed really in concert with the community and was designed to be a welcoming, accessible service. And then on the right is what was colloquially known as the Big Red Spaceship, which was the big clinical building that it got moved to, and it was really, the whole building was designed around one-to-one care of individuals. So it really was an embodiment of how much the principles driving the sector had moved away from the original community health service principles. And lastly, the last dot point on the timeline was in 2012, we had the review of non-hospital based services, which was known as the McCann Review, that, as Fran said, basically pretended that there wasn't any evidence for any of this community health malarkey that had been going on for decades, and anyway wasn't it the job of the newly established Medicare locals to be doing health promotion. And in 2013, the government accepted all of those recommendations, and essentially that was the end of the community health sector, mainstream community health sector in South Australia. And then in 2015, with the new health minister, we had the Transforming Health Strategy, which had one paragraph at the start essentially arguing that primary health care was now solely the remit of the federal government. And so that was kind of really signalling that there was no longer any state support for the kind of work we're talking about. So thank you.
Thanks, Kathy. So I'd also like to begin by acknowledging the Burramadigal people of the Durack Nation, on whose land we're meeting, and pay respect to their elders past and present. So in this presentation, I'll provide a short summary of the development of the Australian women's health movement and centres from the 1970s, and focus on some examples of the unique contribution of the women's health movement to the health system and to progressing gender equity in Australia. In the 1960s and 70s, the women's health movement developed as part of a broader feminist movement. The women's feminist health model which developed was in response to a dire need in the community, particularly for poor women marginalised by mainstream health services. So prior to the funding from the Commonwealth Program, feminist activists and women health professionals in the 60s started to form women's health collectives and volunteered their time to build from the ground up women-centred and women-led health and social services across Australia. This led to unique models of women's health services, which developed within different states in response to the community, needs and local contexts. So, for example, in Melbourne in the early 1970s, the Melbourne Women's Health Collective formed. Lynn McKenzie was a young doctor at the time and one of the original members of the collective. She said in her interview, every Saturday afternoon, the whole collective used to gather at the Women's Health Centre and talk about how we worked collectively. And there was a lot of discussion about women's liberation politics and what that meant for women in the community. Lynn told us both the Women's Health Collective and the Women Against Rape Collective had a real impact in demonstrating the need for future funding and delivery of services for women. The Collingwood Women's Health Centre then developed out of the collective in 1974 and received federal funding from the Community Health Program. In New South Wales, which I'm sure many people are aware in the room, following the International Women's Day March in 1972, a Women's Commission was held in Sydney where hundreds of women publicly told their stories for the first time. That led to the establishment of an early health and abortion service in Sydney called Control. The Control Collective then developed into the Leichhardt Women's Community Health Centre in 1974. So just some examples of these early centres, health centres, pioneered collective and community models of management and services. So some of them included flat pay structures and job sharing, and would train health professionals and community members alike. Participants told us how these early centres were a catalyst for other women's health and social services, and capacity building for people working in women's health, but community health more broadly. So Elizabeth Reid, the first advisor on women's health appointed by the Whitlam government in 1973, referred to the era when Whitlam was in power as when feminism met social democracy, meaning this was a time when feminist and other social movements enabled the state to make changes to improve social justice through social reforms that address the social determinants of women's and others' health. So funding from the 1973 Commonwealth Community Health Program gave critical support to women's health centres, initially funding 7 women's health centres and a variety of other women-centred services. The first National Women's Health Conference in Brisbane, held in 1975, brought together women's health advocates for the first time, creating a national network which fostered political change into the following decades. From the 1980s, while funding was handed over to state governments and there was severe cuts to the Community Health Program, as we've heard, political and social support for women's health largely grew. Femocrats were gaining more positions in government and the bureaucracy, as seen through the formation of women's health units, with women health advisor positions being set up at the Commonwealth and in the States. Major inquiries into women's health were also held, leading to the development of state-specific women's health policies from the mid-1980s and new women's health centres opening. This growing support resulted in the National Women's Health Policy and Program of 1989, the first of its kind in the world. The Women's Health Centre model was characterised by women-centred services with community boards of management. Services were free or low cost, multidisciplinary, holistic, locally based, often in disadvantaged communities, and provided community development, health promotion and prevention activities, alongside specialist women's medical services. This model explicitly understood women's health issues in relation to the social determinants of their daily lives and broader social structures. So before moving on to the post-90s, I wanted to highlight 2 important strands which developed in the women's health movement and still underpin the movement's philosophy today, that being health promotion and advocacy and women's health working at the intersection of oppressions. Health promotion and advocacy in the women's health model go hand in hand. For example, the 1988 South Australian Women's Health Centre's strategic plan supported the idea that advocacy was a part of the service and included social action as one of its principles, stating women's health centres involve and mobilise the community for change and advocate for change in public policy and the health system. Within the centres, as Claire Shuttleworth stated, the advocacy work was accepted. It was seen as a part of what women's health does. In Victoria, advocacy and health promotion developed through multiple forms, and they have been leaders nationally in this space for decades in women's health. So, for example, data collection and evidence to inform health services, health promotion, advocacy and policy started early through the Women's Health Resource Collective established in 1983 and Health Sharing Women in 1987. The two organisations amalgamated in 1993, forming Women's Health Victoria. Today it is part of the Victorian Women's Health Network and is an independent, feminist, not-for-profit statewide organisation for women and gender diverse people's health, and plays a key role in Victoria and nationally in the advocacy space. So, in the stories of how women's health centres developed across Australia are examples of how they were at the forefront of addressing different forms of oppression. And this has included being confronted with their own privileges and power structures, in particular with migrant and refugee women and Aboriginal and Torres Strait Islander women often not having their particular needs represented in feminist spaces. Due to women's health centres being in locations where high numbers of women from non-English speaking backgrounds, poor women and Aboriginal and Torres Strait Islander women lived, the women's health centres realised they needed to be more responsive and more inclusive in both their services and their advocacy. So an example of this was in the reaction to the 1989 Women's Health Policy, which was criticised for not acknowledging the unique needs of women from non-English speaking backgrounds. In response, the women's movement worked with groups of non-English speaking women to develop the non-English speaking background women's health strategy, outlining the main health concerns of these women, and drew on the experiences from women who use the women's health services. Women's health centres have often acted as catalysts for other women's health and other community services. So, for example, the Liverpool Women's Health Centre in New South Wales in the mid-1970s had a large amount of South American women clients who had workforce injuries. This led to Liverpool Women's Health Centre being instrumental in supporting the establishment of the Workers' Health Centre in Sydney. There are many more moments of intersection, challenges and solidarity to explore, but I'll move on. So from the 1990s, a diverse range of both mainstream and separate women's health services and programs were in operation. However, women's health centres faced increasing institutional, financial and political constraints, many of the same outlined by the other presenters today. And the mid-1990s in particular marks a point at which women's health centres departed in how they developed in Victoria, South Australia and New South Wales. In general, since the 1990s, there's been a political and financial decrease of support for separate and independent women's health centres. However, important to note is the impact of the women's health movement on mainstream services, education and policy in general. So to summarise the current context extremely briefly, South Australia is probably the bleakest story, so I'll start there. Since the 2010s, women's health centres have been completely incorporated into government-managed services under the banner of the Women's and Children's Health Network, where they remain today, with some residual women's health services in the community. In the mid-1990s, the Victoria Women's Health Movement reorientated its strategy to population health promotion to reach a greater number of people through prevention, promotion and shaping of mainstream health services and policies. So a network of 9 independent regional services and 3 statewide women's health services covers the entire state, and are largely no longer able to provide direct women's health services, but support other community health and mainstream health to provide women and gender specialist services working to improve health services and gender inequities. And lastly, in New South Wales, 20 standalone women's health centres which are based on a women's-centred approach to comprehensive primary health care have remained throughout the cuts and integration of other women's and community services into the mainstream system. So women's health centres today are unique in the New South Wales health landscape, as they're an example of community health services which largely sit outside the bureaucracy, but are positioned as an essential part of the New South Wales primary integrated care system. And I thought I'd end on a good point, and I'm sure many people are aware of this in the room. So from 1986, the centres did not see a real increase in funding. However, the Minns Labor government allocated $34 million to women's health centres in September this year. So I'm sure we all look forward to seeing how that unfolds. Thank you.
As a Wallian woman, I'd like to add my acknowledgements to the traditional owners of this country that we're meeting on, and I'd also like to acknowledge other First Peoples in the room today, and really pay my respects to elders and leaders who gave time and wisdom to our project. As you've already heard today, in 1973, the first Aboriginal community-controlled health organisation was established in Redfern, and this was part of an ongoing expression of our sovereign rights that had come to the fore in the 1960s. That social movement, which emphasised community control and self-determination, was informed by the Redfern Black Power movement and the Charles Perkins 1965 Freedom Ride in civil society protests across New South Wales. Those acts of sovereign resistance have continued, and in 1973 other organisations were also influenced by the Aboriginal community-based and self-determination movements. I think it's also important to note that the contribution of the Aboriginal community-controlled health organisation and service hasn't always been seen in the mainstream health system in this country. An important part of this project was to make that visible. So some of the achievements of the Aboriginal community-controlled health model is very much around the importance of a multidimensional view of health. For First Peoples, that means physical, emotional, social, cultural and spiritual dimensions of health and wellbeing. And from a service perspective, that meant a service placing people needing care in the context of their community. So coming at healthcare from a collective mindset. And this definition of holistic health speaks to the need for that to happen for Aboriginal and Torres Strait Islander people, but also what that means for us as human beings generally. And this definition was also referred to in the seminal document, the National Aboriginal Health Strategy. So the Aboriginal community-controlled health movement has been able to establish some really good evidence and best practice about what is comprehensive primary health care in the Australian setting. Selwyn Button, who's the current chair of the Whitlam Institute, says, now we've got more evidence that you can poke a stick at that shows that the community control model of healthcare, which is a comprehensive primary model of care, makes the most difference in terms of improving outcomes for Indigenous people. And what Selwyn speaks to there is the need for us to be applying evidence in a consistent and sustainable manner, and that has been a real challenge for the Aboriginal health system in this country. Jill Gallagher shared with us that not only your cultural determinants of health, but your social determinants of health, which means employment, housing, drug and alcohol, mental health, and the list goes on. Rumballara also has, I think, 5 dental chairs. That hub, you go into the Rumballara doors, you can see a nurse, a health practitioner, a doctor, a mental health, a drug and alcohol counsellor. If you're looking for aged care, they've got an aged care in the home, residential aged care and housing. Most of the VACHO members have their own housing stock. All of those social determinants, and you can list them, health, housing, employment, and the list goes on, our services deliver those. She was talking about the importance of a one-stop shop, the positive impact that it has when people aren't needing to repeat stories that are traumatising or that might expose them to victim blaming. What others have already said today has been shown very much in the way in which health is a community affair. The Aboriginal community-controlled health movement has exemplified how community governance, how community control, and how community participation can be done. It's not impossible, it is achievable, and this is one of the greatest gifts the community control movement can give to our health system. And fundamentally, community health is about that collective advocacy, a collective advocacy to drive change and reform and to respond to the needs of people rather than the needs of politics. What the Aboriginal community-controlled health movement had to do was to find the different agents and levers for change. And they were able to do that as a collective group and have been able to withstand over time serious threats against their existence. And thankfully the Minister this morning has already spoken these next two slides, in effect. The fact that an Aboriginal community-controlled health model is good for all Australians. They all want to adopt our model, and you know, everyone wants to adopt our model. Even Greg Hunt said, and Minister Butler said, but you know, he said rural health should be the same as Nacho. It's the best model, he said. I said, well, you know, it's not just rural communities, Minister. You should have it right throughout Australia, for every Australian. And that's from Pat Turner, who unfortunately was unable to be with us today. The Aboriginal and Torres Strait Islander community-controlled health movement has fostered an ongoing visibility of Aboriginal community-controlled health organisations and services. And this is despite ongoing racist and colonising forces which attempt to marginalise and disempower Aboriginal and Torres Strait Islander people and organisations. And this includes the recent reminder that our own voices are considered irrelevant in our own homeland. Today there are approximately 140 Aboriginal community-controlled health services across Australia, and there is a lot of evidence that Aboriginal community-controlled health services are the most successful and comprehensive models of primary health care. And importantly, the outshows have extended our thinking about what a decolonising primary health care practice is. And it's basically healthcare that addresses those negative impacts of ongoing colonisation. They're expression of sovereignty and self-determination. They're led by Aboriginal and Torres Strait Islander ways of knowing, being and doing. And importantly, decolonising practice challenges power imbalances in all structures formed in society. They promote connection to country, to culture, and pride in our cultural identity. They mobilise Aboriginal leadership and governance, and they prioritise Aboriginal staffing, employment and training. They create culturally safe spaces for treatment, healing and health promotion. And they work from a strength-based mindset. And so we have the evidence that we need around community control. And this project that we've been involved in shows that we need to keep applying it and that it has a broader applicability. Thank you.
Thank you, Tamara, and all the research presenters. We are running a few minutes behind, which I think is fine. I think we need to engage with some good Q&A. Again, we have a roving microphone, and I'll ask the researchers to stay seated, and I'll hand you a microphone as well. And we have a question over here, Viv, first. Right here. I think it was right there.
Thank you, John, and thank you, the Whitlam Institute and Fran Baum and colleagues for indulging us this afternoon. Stephanie Shorter, Health Policy Analyst. This is my idea of a fun Friday afternoon. Thank you very much. I want to make two comments, if I may, John and colleagues, and a question. And the comment is regarding the importance of the factions within the Labor Party. We're clearly very well served by Minister Butler, who is a senior member of the left faction of the ALP. And I wonder if James or somebody else can confirm that my understanding of the Hospitals and Health Services Commission was that it was a sop to the left faction of the Labor Party and socialist doctors in particular and left-wing health professionals who wanted a National Health Service introduced in Australia. And they knew the limitations of universal private medical care or publicly subsidised private medical care. And in knowing that the Hospitals and Health Services Commission and the services they funded, including the community health services, were a sop to or a concession to the left of the Labor Party and left-wing doctors and health professionals. So that's my understanding of the history of the community health program vis-a-vis Medibank. Secondly, I'd like to commend Denise for emphasising the role of social scientists and Connie, the feminist health professionals. And I think you might be underplaying the significance of the role of left-wing health professionals, including doctors. And just very concretely, I'm on the board of the Women's Health Centre on the Central Coast. And Debbie Notara in the 90s as a social worker halved her salary to work as a community worker in the Women's Health Centre. So she was halving her salary because of her commitment as a feminist health service provider. And that brings me to my question for, I guess, the panel overall, whether you're going to make any general conclusions about the value and the effectiveness of geographically based community health services vis-a-vis special interest community health services for women, Aboriginal people, young people with mental health conditions, for example. Thank you.
I don't want to say much. I think that was well stated. That some of those dynamics definitely emerged from our oral history interviews regarding the kind of factionalism and the sort of play beneath the public rhetoric, the kind of things that made their way into public speeches and by politicians. There was some of that push and pull and tussle behind the scenes. Yeah, I think somebody else should speak to the rest of the question though, because it's a very valuable question. But I don't know who.
I think we should be paying, since we've been mentioning all the senior people from the Whitlam period, we should mention Moss Cass, who grew up and set up the Western Region Health Centre and who made himself such a nuisance to Gough that in the end Gough wouldn't speak to him, that Gough gave him the environment to poison his life and stop him from from pestering about community health. And Moss refused to accept that fee-for-service was a locked-in institutional arrangement, and that he felt that we should be looking for approaches to healthcare delivery which were much more flexible. And so clearly the Hospital and Health Services Commission was part of that. But don't forget Paul Gross was part of it, who ended up as I don't know if he has ended up, but as a serious policy analyst for the right wing, and has, over a long period of time, has promoted a right-wing approach to health policy. So it wasn't just a pink wash. It was nicely balanced, really.
I think it's worth adding, Stephanie, that the conclusion or the comment that the community health program was a concession to the left was something that Nancy Milio included in her analysis of the community health program. And again, I think it's important to mention Nancy, a professor of nursing from the University of Chapel Hill in North Carolina, and she was invited by Sid Sachs to come to Australia in the 80s and produced a whole series of very important publications on analysing the community health program in Australia. So she's certainly somebody that we pay tribute to, but that was certainly her conclusion too. Do you want to talk about specialism?
Sure. So that was a question around whether we'd be supporting recommendations to support specialist services, whether they're geographically located or about...
It's more a question about the value of geographically based services, i.e. generalist services, vis-a-vis special services such as women's health services, Aboriginal services.
I think we'd argue both are important because they serve different functions. I mean, I think, you know, just speaking about women's health services, obviously still having that safe space for women to go and I think is still really important. And I think some of the participants talked about a struggle of, you know, especially in the 90s when amalgamations happened, that a lot of the generalist community health services wanted to kind of take over the women's centres and women's health services, and the importance of kind of working in solidarity with each other rather than competing for funding, and recognising the importance of both. That doesn't mean that generalist community health services can't do women's health or other specialist services, but yeah, I think we'd support recognising the unique contribution of specialist services.
Should we take another question? I think behind you, Fran, there was a hand. Is there a question over here? Do you have a question? No? Just over here. And you're there. Thank you.
I'd just like to pick up a point that Fran mentioned in her talk, which was, I think, if I'm not misquoting you, that community, if a submission had the words community development in it, that it wouldn't get funded. And having worked in women's health and women's health promotion myself, it seemed to me that community development was really key in local communities in addressing social determinants of health. And that was embodied in the women's health policy outcomes framework in the early 2000s. So it just seems to me, like, I guess I'm wondering if this rising numbers of mental health, mental poor health is not related to this kind of winding back of a community focus.
Thank you. Can I firstly say that I would like to acknowledge, I think part of the rising mental health is climate anxiety, made worse by the fact that our governments are doing so little to combat the existential threat. And I think every time Tanya Plibersek approves another coal mine, I think the mental health of young people goes down. So, you know, I get the role of social media and other things like that, but what my wife sees coming through her door as a clinical psychologist of children and adolescents, and from other data, climate anxiety is a huge part of the growing mental distress of young people. Secondly, I completely agree about the value of community development, and part of the story is ideological, I think, of a belief in biomedicine, and people come in when they're sick and get treated. I think part of the story that we've been told is the managerialism that crept into the health services from the 90s onwards, where it went from having that local responsiveness to design and develop community development in partnership with the community and in direct response to their expressed needs, became replaced with the need to program logic and justify every single hour of your day, you know, with the full kind of case proposal of what the outcomes would be, in a way that started to shut down some of that innovation. A number of people told us that part of it. So I think there's lots of barriers in the way to reinvigorating community development in the health system. I guess we're seeing it elsewhere. We're seeing it in non-government organisations and maybe in local government and places like that. But I'd really love to challenge those barriers and see it back in the health system. I completely agree with what you're saying.
Anyone else? We have a question over here. Viv, can you bring the...
Thank you, and thank you to all the wisdom that's been shared across these sessions. My question is, I've been really sad. I've been involved in community health in some shape or form for many years. Is the diminution of community, not just community development. And like most of the titles of the standalone centres in Victoria don't even include community anymore. You know, I'm from Mary Health. There's, you know, things became STAR. The community health bit's been dropped. And I think it's really, you know, there's a real time now to reclaim that, especially out on the fringes where there's developing suburbs, where there's a huge need for community-based services and not just primary care. I think that whole shift of primary care just lost the whole point of community health. You know, it was more about allied health services and chronic disease management. So, you know, I think the next session I think is going to be focusing on some of that, but I'd just be interested in people's comments about what we can do to add to that and to argue for that importance ultimately, because I think terribly sad what's happening in South Australia. And I think the whole fact that Yes didn't even get up very well in South Australia, you know, we're a far cry now from the Don Dunstan day in South Australia, and I cry for your program, Fran. You know, I think it's just awful. So anyway, enough from me.
Can I respond? When the federal government says that we need to do something about excess carbon dioxide pollution from the gas industry, they're very, very cautious. They invite the gas industry to come forth with self-regulation, with gentle regulation, responsive regulation. If we had the same political force behind an institutional system that could address effectively the social determinants of health, including climate, whatever he called it, climate anxiety, alienation, housing, inequality, we would be in a better position to protect institutions with the operational continuity of staffing, managerial discretion, and appropriate local accountability. So, for me, the issue of building community governance and community control, which would be about building a capacity to challenge I must control everything from the Secretary of the Health Department to I must allow some discretion at this community level. It is about power.
Shall we have one more question? I think we do need a break. So we'll have one more question here and put it to the panel. Thank you.
Thanks very much. David, I think I want to turn around a little bit what you've just said and also refer back to what you said to the Minister. Also go back to what Toby said about climate anxiety and also I guess in some ways this is addressed to Tamara because, you know, what you mentioned earlier, David, and what comes through so strongly is racism. There are so many structural problems and I wonder how from the ground up or from community health anything can be done. I mean, you know, you say, David, if the government had a different point of view, then maybe things would be better on the ground. But how can anything be done at the ground level? How could community health address these massive problems of the climate emergency, of housing crisis, of inequality, and of profound racism in this country? Can anything be done from community health? Bearing in mind that Tamara's already told us how Aboriginal people from us grabbing their own sovereignty can do it, but what else can be done
I think the story of Aboriginal community control and the story of women's health in women's health, community health and women's health tell us that massive things can be done. The situation has been, in both respects, there have been massive changes over the 50 years of the community health program. I'll shut up and ask someone else.
Thanks, Dad. Thank you for your question. I was in Victoria unexpectedly the weekend of the referendum. I had to go to an international polling booth. And I had to walk from one side of the street to the other. And as I was in the median strip going over the last bit, a car drove past and just hurled abuse at me. And for the first time in a long time, I actually felt unsafe. And then I thought, well, stuff that. I'm not, you know, I think at some point we take our own power. More practically, if we're not going to be talking about voice and treaty, well, then we need to start truth-telling. And we need a truth-telling process that speaks to whiteness and to blackness. We need a truth-telling process that is about a connectivity to each other and to this place, this beautiful country that we're privileged to live on, that we're slowly killing and selling out our grandchildren's future. We need to have a truth-telling process that changes our relationships. And we need to come back to the sovereignty of this place. We walk this place, every single one of us. Every single one of us walks this place, which binds us together. That's what makes us Australians. And fundamentally, when Aboriginal and Torres Strait Islander people talk about power and express aspirations to have power, what they're expressing isn't about taking power away from someone else. They're talking about shared power. And so rather than people thinking that they're losing something, we need to change that narrative to understanding that we're gaining something. And that's what power sharing is. And so when we're talking about power dynamics, we need to change the notion that power is some sort of finite commodity. It's not. It's like love, it's endless, and it can be shared, and there's enough for everyone.
So what we're going to really concentrate now, what are the lessons? And I think you've all got a copy of the policy brief that we've written, which is some of the lessons we've derived, and we're planning to update that after this afternoon on some of the insights. You've already met Tamara, Denise, and our other panel. I'll start with Tony McBride. Tony's also an investigator on the History Project, and he's worked many, many years in the health sector. He's currently chair of Your Community Health in Melbourne's Inner North and a director of the Victorian Healthcare Association. And he was previously the CEO of the Health Issues Centre, which did some fantastic policy work. And then Kent has very kindly stepped in at the last minute because Nicole Bartholomew had a family bereavement and wasn't able to come. And Kent is the CEO at Your Community Health, and he only heard yesterday, I think, that you were going to be on this panel, so thank you very much, Kent. And he's worked in community health for 20 years. I'm glad to see he's got a Masters of Public Health, and it was originally an occupational therapist. And I reckon occupational therapists get social determinants more than any other health professional. They really do. We've worked with some who really do that. Then Ben Harris-Roxas has been a health service researcher for over 20 years. I can't believe that, Ben, you've been there. And he's now a senior lecturer in integrated care at the School of Population Health at the University of New South Wales, particularly looking at how you can have better services for culturally diverse people, people with disability and carers. And Ben's won a lot of research money and done a lot of research in that area. And then Simon, who I'm going to address the question to first. Simon Cottrell, who works in the Federal Department of Health. He's the first Assistant Secretary of the Primary Care Division. I guess one of our successes is when he's first Assistant Secretary of the Community Health Division. That may happen. And he's leading work on the strengthening Medicare agenda that the Minister talked about, and he has chaired several national committees on disability health, and you've worked in government for 33 years and you're still standing, so that's really good. And he was awarded a Public Service Medal in 2012 for his work on the tobacco plain packaging and tobacco control in Aboriginal and Torres Strait Islanders. So you must be particularly miffed to see the rise of the vaping. When we thought we'd got it in public health, we thought we'd done a good job, and the tobacco industry was far too crafty for us. But anyway, so Simon, to start, well, I'm going to ask each person just to address a question for 2 minutes, no longer than that, and then I'll open it to questions from the floor because you've been sat listening a lot. So the idea here is we want to have more, but we thought we'd just get everybody a chance to speak. So Simon, you heard the Minister Butler's speech and the work about implementing the primary care 10-year plan and the strengthening Medicare and primary care reforms. What do you see as the opportunities and challenges for community health as part of those reforms? That's obviously what we're very concerned about.
So thanks very much, Fran, for the welcome and for the question. So you heard the big themes the Minister was talking about. So more investment for people who are facing social and economic disadvantage. And the big investment in the budget on that was in bulk billing. Oh, if it hadn't been in bulk billing, we had some ideas, but it was in bulk billing. The second element is the My Medicare system of voluntary patient registration. So at the moment, that is very focused on general practice, but the government has ambitions to broaden that.
Right.
So it's already got on the table removing the requirement for collaborative arrangements from nurse practitioners so that they can lead practices that people might register with, looking for ideas about how we broaden our concept of primary care and you know, people's healthcare home, for want of a better word. That's a bad word. but the place that people go for their regular healthcare, including chronic disease management. So there's some future directions that have been set in that work.
So could a GP in a community health centre attract one of the packages?
Absolutely.
Yeah.
Absolutely. So if a community health centre has a GP now, we would be encouraging community health centres to become accredited general practices, and many of them in Victoria are. And then they can attract all of the funding that flows with that. So the practice incentives, the workforce incentives, the new incentives that we attach to My Medicare. So, you know, and this system, so in the previous government's primary healthcare 10-year plan, which this government has not discarded, they've prioritised it through the Strengthening Medicare Task Force report. There's an ambition to bring the proportion of block or incentive funding up to 40% of funding in primary care, with the remainder being fee-for-service, but not by taking away fee-for-service, by adding additional block funding. And I think when people talk about blended funding, and David talked about that, there's kind of two aspects to it. One, the block and the fee-for-service, but also the Commonwealth and the state blends as well, and this government very interested in that. So, and the Minister didn't talk about the National Health Reform Agreement, which we're about to enter into discussions about the next one, and primary care and potentially community health are very much part of that conversation, Commonwealth to state.
Hopefully today will have reinforced in his mind the importance of community health. So Ben, I'll come next to you, because I think you've been looking at some co-commissioning activities. What do you see as the challenges and opportunities there? Presumably that also includes the primary health networks.
Yeah, look, I think there's two main challenges we're encountering when we look at co-commissioning. One is the lack of a shared language about what even is community health. Some work that I did, a small piece of work with Jenny and Virginia Lewis, we found when we looked across all the states, no commonality essentially in terms of what's in community health and what gets described as community health. Really none. And so that creates a real challenge because also there's very limited visibility in terms of what gets accounted for, to speak to Denise's question to the Minister earlier, in terms of what is community health and community health expenditure. The other thing is it's very difficult to, even in a co-commissioned context where state and PHNs in this work that I've been thinking of come together to commission services, to do that in a way that doesn't increase fragmentation. So there is this challenge where we can see the promise and so much of the strength of Whitlam's community health program was that it was comprehensive and enabled continuity of care. And it didn't involve having to navigate a minefield of services and schemes, which is really a major challenge for people.
That's one of the things it set out. It actually says very explicitly in that programme that there were overlapping and misunderstood services. So it's interesting we're still talking about that.
I mean, still, the idea of how do we access multidisciplinary care in the community in ways that make sense to people, the original goal, it remains relevant.
Yeah. Okay. So can you give us a bit of a feel for what your community health service does, I guess? That's really important. And kind of what are the sort of pain points that you have in terms of funding?
So I think at organisations like mine, which is an independent community health service, and there's a network of across Victoria of both independent and integrated community health services, we have managed to thrive despite the changing policy and funding environments because we can be adaptable and flexible, because we bring together a whole lot of funding sources, as Simon mentioned, state and federal, and then we partner with local communities to work out how to meet their needs within the constraints of that funding. So we're very good at pulling things together, but remaining as true as we can with that money to health equity principles, social determinants of health, upstream work. We continue to do community development. We continue to do health promotion. We run many group programs, both in social health and clinical care. So the elements of the community health model remain, despite the fact that only a small proportion of our funding is now considered community health funding. But because we're independent organisations across Victoria, we are able to maintain that focus. It's built into our constitutions, it's built into our boards of our community boards of directors. So everyone that comes to community health from a staff and a board director point of view is usually committed to that social model, which allows us to continue to do that work despite sometimes a less than supportive policy environment.
Yeah, so just one more on that. The Minister talked about deserts of access. Would your area where your centre is be one of those, where the inverse care laws, where the high need but low provision, is that the kind of...
So we have a swathe of public housing across our parts of our northern Melbourne, and there's a lower percentage of doctors and certainly bulk billing doctors, and certainly those cohorts are not able, even if they can access a GP, they cannot access allied health services without services like ours, and certainly not in the bicultural or community-specific way, whether it's LGBTIQA plus community-led services or whether it's working with our local cultural groups. They would not have that access without services like ours.
That's great. So, Tony, coming on to you, we've talked a lot about this word community and what it means, and you've worked for so many years in community health. What do you think is the value of this community focus, especially in terms of challenging social determinants?
Well, I think there are multiple values and aspects to it. I mean, just using the word community doesn't, I can remember that famous article back in the 70s about community, the spray-on solution. We need to take it seriously when we use the word. But I think it has several parts to it. As an organisation based in a community or a set of communities in reality, it makes the focus local. it helps you build relationships with a whole range of communities and small populations over time. And that really paid off in the pandemic, where it was the community health centres that actually had the relationships to work with those very vulnerable, disadvantaged communities where a lot of the workers who had to keep on working were based, and where there was a great need to vaccinate them and support them. The department relied on community health actually to do that work in the public housing towers, or actually in small ethnic communities, or in all the sort of supported accommodation places. The health minister said afterwards, we couldn't have tackled COVID in the way we did without community health. So it was that sense of connection with the community that was really important. It also means that when we're just talking at a board level, we are conscious, we're constantly referring in different ways to, how what we're doing or should be doing relates to what we're hearing about community need, or if we want to make a change, we're conscious we have a membership, we actually have to sell this change, maybe it's a major change to the membership. So, it infuses, I think, everything we do and the way we act. So it's not just about we provide services, and we'll decide what the services are. I think there is that infusion constantly. Yeah.
Okay, great. Now, Denise, I'm going to imagine that you're the Federal Minister of Health. How would you make the community health sector more visible?
A lovely fantasy. The first thing I'd do, I think, would be to ask the Commonwealth Department of Health, or to set up within the Commonwealth Department of Health, either a unit and or with a advisory group from Community Health Services with the task of being able to describe a national profile of community health services and centres, because that's what we don't have at the moment. And even just very basic things like what services are included. I know it's a complex definition, but at the same time, how many? How much money? Where are they? So the most basic things we don't have information about. And also, as I mentioned in my question earlier to the Minister, when I looked at reference documents that many people, including politicians' advisors and policymakers, would go to for information about the health system, the Australian Institute of Health and Welfare's I think biannual report called Australia's Health, and also the Productivity Commission's report called the Report on Government Services, or the ROGS document, it's known as. Neither of these things have any description or the most basic data about community health services. So here's this large sector which is unknown. Also in New South Wales, there's a Bureau of Health Information which collects and publishes very detailed information on hospital and ambulance services, including their waiting times. No information on community health services. So I guess I'd do two things as the Federal Health Minister. I'd be prompting those organisations that the federal government funds to include community health as an important descriptive category that they need to know about. And I'd also be working with states, prompting states to do the same thing at state level.
Okay, thanks.
Yeah.
That's pretty good. Tomorrow I had an interesting chat with Warwick, and he was making the point that maybe the reason that some of the women's health centres have survived in Aboriginal health centres was that there were social movements behind them, and there's no longer a kind of a class social movement as there perhaps was more in the 70s. Do you want to talk a bit about how important kind of the Aboriginal health movement has been to maintaining and strengthening ARCHOs and ending up with a model that everybody now recognises much more like comprehensive primary health care should be?
I think that First Peoples of this country have always asserted their sovereignty. This is unceded land, and that deep bond to place creates a different set of obligations and responsibilities, and that deep attachment to place and people drives different actions. And so the sanctity of place and people is what drives Aboriginal and Torres Strait Islander people to maintain connection to place, maintain connection to each other. And those civil society movements that led to the place where a community-controlled health organisation structure could emerge actually have their roots, 40, 60, 100,000 year old roots. And that's why I think Aboriginal leadership and why the Aboriginal community-controlled sector continues despite what have been some very concerted efforts to take it out, previously at least, and why, when you look at the history of this country, every 30 to 50 years there has been a movement from Aboriginal people about their sovereignty. So we'll have another crack.
I hope it doesn't take 30 or 40 years. I spent 3 years working on the WHO Commission on the Social Determinants of Health, and we had on there a former Canadian Health Minister, Monique Béjean, and she made a very powerful speech about how she thought Canada was the land of pilot projects. And I have heard the Minister say before, though he didn't say it today, that he thinks we have more pilot projects than Qantas, or more pilots than Qantas. So I'm just wondering, Kent particularly, and perhaps Tony as chair of the board, is that frustrating to you when you get all these little packages of funding, or have you managed to escape that in your service?
I wish we'd managed to escape it, but I mean, and I think this is true of any work with community, is that you enter into a contract of trust with your community when you establish services, particularly if you're working in that partnership space, and often it's not okay to come in and do a 12-month or a 2-year project and to establish that something can work, only to have to take it away. And it's even more not okay when you're working with communities of lived experience, as we increasingly understand that we do, to provide an opportunity and a pathway for people to work within their communities, and then to take that away. So not only you're taking away from our community members, but also those people that become staff. So it's something that we work really hard to try and fight against, and again, it's part of that patchwork of funding, but it's certainly a huge problem in the sector.
Yeah, okay, and you certainly don't see hospitals funded in that way. They have much more central funding. Okay, so any questions from the floor? It's front.
Jenny McMillan from Trobe University. It's not so much a question, I guess, as a comment, and it refers back to the comments that were made earlier about, should services be specialised or should they be universal? Just thinking about it, I mean, we're all, I assume, happy that there's women's health services, there are specialist services there. But I'd like to stress that it seems to me it's really important that, although you applaud what Simon was saying and the Minister was saying in relation to, making sure that there's access for vulnerable communities and the whole gamut, I suppose, of people that are covered by that. But I'd really hesitate to be advocating for something that is only going to focus on that, because then you end up with a welfare service, and if you've got a welfare service and there will inevitably be a change of government, it will then be targeted inevitably as a welfare service for the undeserving poor. And so I suppose it's just, I don't know whether anybody has any comment on that, but I think it's really important to, as somebody that previously has worked in community health, that the service stays universal rather than, sorry, I'm losing my voice, rather than become a welfare service.
I think, Ben, you were indicating.
Just to agree, Jenny, but also to note that if we're thinking about how we achieve health equity, part of it is moving away from thinking of just solely universal services or targeted services, and recognising that if we're talking about proportionate universalism, so this is services available everywhere but can increase intensity to the people who need it most, the community health sector is really the only part of the system that has that capacity and plays that role. So just to emphasise what you're saying, that, you know, that ability to respond and increase the intensity of engagement is a really key feature of community health. So just...
Yeah. One of the things that I think is a constant that we found in the history of community health is this idea of evidence and whether there's enough evidence for community health. I never hear people asking that much for general practice, you know, or hospitals, but you know, but it just seems, and that the McCann Review in South Australia actually stated there was no evidence for community health, which, having been director of a community health evaluation service for many years, and I'm sure many of the other panels. But Denise, you initiated one of CHASP, which was the Community Health Standards and Accreditation Program back in the 1980s. Would you agree there's no evidence for community health?
I think there's a lot of evidence for community health, and within that there's evidence about what's been implemented, what's happened, its need for it, and what's worked and what hasn't worked. So it's a body of evidence which, like any body of evidence, when you look at it closely, is nuanced. But again, in the ideological debate about evidence, there's this notion that it's either scientific with a big S and it's good, or it's fuzzy and it's not good. And the other thing that always strikes me in terms of nuance is that if you actually look at evidence or information about hospital-based clinical services, we find that some services work and some services don't work. Or they work for some people but not for others, which is, you know, a nuanced approach. But again, in the binary world, or the world of simplistic approaches to evidence, there's somehow this notion that everything has to work for everybody all of the time. And I think that's been problematic for community health. And there's also been that whole debate about methodology. And again, I think the evidence-based movement and the outcomes-based movement resulted in a narrowing of the debate about evaluation methodology and what was acceptable. And I think too, the dominance of epidemiology within public health has also contributed to that. So when you actually look at the evidence or the history of work on evaluation and evidence in community health, you find a great range of work. There was some work from the early 80s in Queensland which looked at collected data at, I think, 2 community health centres in Queensland for a period of 3 weeks. And I think it's fair to say Queensland was a fairly untypical state for community health in the 1980s. And the conclusion of this research program, after collecting data from 2 centres for 3 weeks, was that the community health program did not work. It was a failure. And that was the journal article which was published as a result. And I suspect, I don't know for sure, but I suspect that notion of community health did not work filtered down into the Fraser government. So there's always a sort of carapace of ideology around that whole debate on evaluation and evidence, which needs to be unpacked.
Okay, thanks. Paul and then...
Thank you, panel. You've already enlightened us enormously with your little introductory talks. But I'm wondering, and I think the Minister referred to this, how the Aboriginal Community Controlled Health Services are seen as, and I think he used the word, a model for everyone. And Pat Turner has been quoted as saying the same thing, and Tamara has already said that. It seems to me that it's a real... tragedy that people who aren't Aboriginal don't have an access to a community-controlled health service. And what I would like to know from the panel is what would need to happen for there to be a sort of movement, the sort that Tamara has talked about, a movement that arose out of many millennia of culture. But what kind of movement would we need to get community-controlled health services for all Australians? What will it take?
Everybody's looking. So I think this goes back to David's presentation of institutional and political barriers, probably. So would anybody like to identify any of those?
I think in New South Wales, one of the barriers would be some pushback from, it would require a change of employment structures. And I can see there'd be pushback from not only the government and professional associations, but probably also the trade union movement, from the Nurses Association and perhaps the Health Services Union, if it was proposed that community health workers would not be employees of local health districts anymore. So it would take a lot of persuasion and debate to make that very fundamental industrial relations change. Yeah.
Ken, did you have something to add on that one?
Can I chip in first? Yes.
Yeah, and then Pastor Simon.
I mean, my immediate answer to your question was a miracle. But if you look at the community health program in the 70s, it was small. You know, it was kind of learning how to do it. You know, it didn't, and yet it has grown, not in a straight line, but up and down as new governments have come in and either, you know, not appreciated or appreciated what it has to offer. So it seems to me that that one of the ways forward is to, and I won't use the word pilot, but is actually for the Commonwealth to fund some centres in some states where there is, you know, an acceptance of that, and to, you know, then to see how communities appreciate that, how they value it. You know, it can be evaluated in a range of ways. I think evaluating community health is extremely complex because actually it tries to do a lot of things, not just a few things, and that is the value of it. It has a broad approach. But I think, you know, it's about sowing some seeds which once, what happening in Victoria was once some areas could see what was happening in others, you know, they were then keen. You know, when the Duckett plan came out and the department said we want to set up some community health centres in other places, there certainly wasn't resistance. Those communities were saying, yeah, we'd love to have that because we've seen what happens in other areas. So I think that would be one small way. It sounds easy when I say it, but, you know, that would be one approach, I think.
I think in Victoria, 50 years is a pretty long pilot. So I'm interested to hear from Simon about how we learn from that.
Yeah. So, well, I was going to say something positive. So, so I was going to say we need to look to the consumer health movement. So in Tasmania at the moment, and Tasmanian government is of the opposite persuasion to everywhere else, but they're funding consumer health organisations in rural communities to come up with what is essentially this community health model, right? And they're driving that, and I think all governments will listen to consumers. So I think that's one positive thing to look to. You know, there's as David said, there's a Commonwealth state game that goes on about cost shifting, and that's very hard. And so I look at Victoria with $150 million per annum put into community health, and all the other states who have either nothing or indeterminate amount. How do we as the Commonwealth navigate an equitable investment in community health from that starting point? Very, very difficult. We can look to particular population cohorts. So, you know, I've done some work on disability health, done some work on LGBTQIA plus health. If we do that, then government changes and, you know, and it's at risk. So, you know, we need to look for universal schemes. We need to look for great big funding streams. So, you know, Medicare is safe. We've had great success, and I feel really proud of my department on the Indigenous health front. You know, we've got a great big continuing funding stream to support the community-controlled health sector in Aboriginal communities. You know, and the MBS on top of that as a blended funding model. So, you know, that's where we need to go, I think, for most things. But getting there from where we are now, difficult.
Just to editorialise from here, I think I'm a little cautious about consumer health movements for one reason, that they're not citizen health movements. And I think the kind of push that Paul wants would come from a citizens' health movement. This came very clear to me when I was president of the Public Health Association, and we ran a campaign to defend Medicare under John Howard, and there was a lot of political annoyance with us. But consumer health, we had a campaign called It Works, It's Fair, It's Medicare, and the consumer health movement wouldn't join it because they wanted private health insurance, because they wanted good health services, and that was legitimate. But I think if we want a strong movement, it needs to be, or a number of us here are involved in the global people's health movement, which is really about taking the position of more an Aboriginal community health service, of all the citizens have access to that. So I think, yeah, consumer health movement's good, but it needs to be balanced by people who don't have a vested interest so much in that. So there, sorry, that's my end of my editorial.
That's good.
Right, we had another question there.
Can I just welcome that, Fran? Because,
sure, yeah.
because it's really hard as a bureaucrat to work in health. It is so complicated. There's so much history you're not aware of.
Yeah.
Right? Like, we don't understand community health in the Commonwealth, because that you focused on crises, and
yep.
it's very hard. We need you. We need researchers, we need advocates outside to be the continuity. I'm pretty long-standing in this job, but that's 4.5 years.
Yeah.
Right?
I know, and that's one of the frustrations with working with federal departments, that suddenly the person you built a relationship with, I know when we've talked to Aboriginal health services, that's their frustration. They build a relationship and then they have to start again. But yeah, sorry, go ahead.
I was just going to raise a question around health and what we mean by health within community health. Like, are we talking about medical services, or are we talking about equity and access and a whole lot of things like that? And one of the things that and the other issue I was, is how we, what informs our definition of health and achieving health within a community. And I remember how helpful I found Tony Vinson's reports that he did in New South Wales and Victoria on by postal code a whole lot of social determinants. And that was just so useful on the ground for picking up on issues, whether it was the number of people who were going to prison from that postcode, which meant then you could look at the number of women who were sole parents or grandparents who were supporting those prisoners. So, this idea of health, my concern with what the Minister said today is that he seemed to kind of start off with individual medical services and then go around and then come back to that. And it just, I don't know, I think we have to kind of drill down is how we determine. The other thing that Tony Vincent said, if you really want to turn around any of these social determinants in an area, it is going to take you at least 10 years. So if you do a 2-year project to start to make a difference and then you don't keep funding it, then it's nothing's changed. And he always argued for 10 years to support a project to really turn a health issue around.
And I mean, you have to remember that he's not really the Minister of Health, he's the Minister of Illness Care Services, because that's what it is. And health is actually happening in all the other portfolios. But I'm sure, Ken, have you got anything to say about how you would see health from the point of view of your service?
I think in Victoria, we're often saying health and well-being now, and which is, we need to adapt, of course, but the true definition of health that we hold as a community health service is obviously about the holistic wraparound, which is about the social model of health and the social determinants, which obviously in the policy and funding environment becomes increasingly difficult to focus on, and we could easily be pushed into just delivering individualised clinical care, but you won't see just individualised clinical care in standalone community health services in Victoria, you'll always see a commitment to the social model of health, to equity, to social determinants, and wraparound services upstream, population, community development, as well as, is it difficult to do? Are you pulling resources, etc.? Absolutely, and we could do so much more if there was a policy environment that actually supported that work.
And I'd really like then, Tamara, if you could talk a bit about some of the work you've done on cultural determinants of health, and particularly perhaps not so much in this history, but in terms of the work that we've done that you led on cultural safety and policy, perhaps.
I think there's things that are similar across, Paul, your question and something about what you said, Simon. It's what is at the centre, what is driving stuff, and I do have to take account of my own profession, and I do think that doctors get in the way sometimes, maybe a lot, but it is about a recentering of people, not necessarily the professions, and so I think that that's a really fundamental part of where we're going, because we treat health service like a business, but it's health care, and we're human beings caring for other human beings, and there's things that happen in that interaction that cannot be commodified, despite best efforts. When I think about those holistic concepts of well-being, they're our social cohesion, our social fabric. And I think that the way that Aboriginal people see, and I should say I'm talking specifically about more Wallian Central Desert Aboriginal people. I don't do work in the Torres Strait. But the way that we are with our country and we are with each other, that collective sense, it creates a different relationship between people. It creates a completely different dynamic, so that my health is connected to everyone's health. My survival is connected with everyone's survival. And so that trying to actually come back to the fact that we are all interconnected, like, race is a social construct. We're actually all human beings. So when we are able to de-centre some of the individualistic, commodifiable pieces of health and healthcare, then we're able to actually open up and have a better relationship with our own sense of wellness in ourselves, as well as between each other and the country. So our wellness is about a strong sense of connection to our place, our knowledges, our songlines, our language, our ceremonies, our practice. And when I look out and I look at people, I see that those things are sometimes not very strong in other people. And there's a myth that white Australia has no culture, but it does. And so on another level, we have to actually be honest about what our values and beliefs really are and where they actually sit. And, if there's a possibility of having people open up to being respectful and loving towards one another beyond the nuclear family unit, then there's a place for the way that Aboriginal people live in this world. Our kinship structures, our responsibilities for this country. Toby talked about it before, that this country is being destroyed, and we're under this delusion that it's not going to affect us as a people. And it will, and it is. And somewhere in there, this notion of community health is about place, and it is about country. It's not just about people.
Thanks, Tamara. I'm just going to give each panel member a chance just to say a concluding comment, because I think we need to conclude now. So thanks, that was a lovely summary, Tamara.
Yeah, I think what Tamara said is very important, and community health has done that connection in two ways. By defining the communities that it works with, it has it means you're identifying a material entity of a place and a people, and then you can understand those health issues there and work from there. But just the other comment I'd want to make about concepts of health, I think part of our difficulty is that what I call the clinical culture of the health system is very deep-seated. Deep-seated both in people who work in it and also in the general public. So there's this deep-seated notion that healthcare is about sickness and it's about bits of the body. And it's as if, I often think that in New South Wales at least, it's as if hospitals have enormous magnets inside them, which draw the funds, the policy attention, and they dominate and distribute their own clinical culture to the services around them and often to people around them. And so this is one of the special challenges, I think, of working in community health in New South Wales.
Thanks.
I think one of the challenges is to actually share the models that are working, around Australia more, because people have alluded to, community health, the successful models aren't well known. When I've worked in New South Wales, people think that they're totally surprised that a community health centre, such as some of the Victorian ones, could even exist. That they exist, or they could even exist. How can you do that? They'd say. So I think there's a sense of people. There are an equal number of people, I'm sure, who are passionate about this approach to community health and the way we do things. It's not as if Victoria just owns that. Far from it. But I think it's about trying to connect with some of those people to help them build some of those models in other states, rather than, we tend to sit in our corner in Victoria, I must admit. And, we probably need to do more in sharing some of that, and some of the work that we've done we need to share. Yeah.
For me, it's been absolutely inspiring to hear about the last 50 years of community health and to hear from people that have been leaders in our field. And I reflect that community health is not just something of our past, it's the opportunity. The principles apply now more than ever, and together we just need to harness and leverage every opportunity to apply those learnings and principles to our future health system, and I look forward to us all doing that together.
Thanks.
The emphasis on community development that was at the core of the program 50 years ago at its inception, I think is something that's going to have to inform our future. 17 years from now, it's almost certain that the world's temperature will increase by 1.5 degrees. That's not just going to be bushfires and heat waves. It's going to be lots of displaced people. It's going to be economic shocks. It's going to be the collapse of social institutions. And the only thing that will protect us against that will be the kind of connections between each other and the kind of communities that we'll need to develop. So I think it's never been more critical, the message of the CHP than it is now.
And that climate issue has kept coming up, so thanks. And Simon, the last word for the Commonwealth.
Well, Fran, thanks for the opportunity. And look, I've learnt so much this afternoon.
Great.
So it's just been wonderful to be here. Please keep teaching us and keeping us honest. There is an opportunity to move, and we are moving. So really welcome the dialogue. Thanks.
Fantastic. Well, let's thank the whole panel.